Good morning to all. We welcome you for this one-day conference on nutrition. It's our first experience of doing an online nutrition course. Also, we should have some international participants with us today. Um, for us, sponsoring and also um, uh, being part of this conference as Malta Leadership Institute is a very important event for us because we believe that people should be empowered and should be um, uh, actually work for their well-being. Nutrition is something that helps our well-being, and we know that healthy lifestyle nutrition is part of a healthy lifestyle, and you will be having also workshops and speeches around also this topic apart from more technical speeches. And we have the pleasure to be part of this conference because also as an institute we have courses that focus on nutrition and dietetics, which one of them will be starting in the coming month. It's a master's in nutrition and dietetics, and we have um, embarked on this project because we believe that it fits exactly within our vision as an institute, that of empowering individuals and also helping individuals to achieve their well-being. Um, Not to take very long, I wish you that you will be having a learning experience. I know online is a little bit different from being face to face. Usually, such conference would be also a time for networking, getting to know people, and virtually it's not always that easy, and hopefully you will enjoy the speeches that you will be having this morning and this afternoon. I believe that we have chosen speakers that will provide you with information but also with their knowledge and experience. So thank you for accepting and coming to this conference today, and hopefully you will enjoy it. Thank you.
Thank you, Mr. Fujiri, for your presentation, for your introduction. Now we have the first presentation by Dr. Simon Gabe. All right. He is a consultant in gastroenterology and intestinal rehabilitation. He is also the chair of the nationally recognized intestinal failure service at St. Mark's Hospital in London. He has wide clinical experience dealing with complex nutritional problems, inflammatory bowel disease, fistula management, intestinal failure requiring enteral or parenteral support, home parenteral nutrition, and consideration of intestinal transplantation. I have worked with him for a number of years, even when I used to work at Mater Dei Hospital and St. Luke's Hospital before that, when we had children with intestinal failure and Great Ormond Street and all that. He has been president of the BAPAN, British Association of Parenteral and Enteral Nutrition. He co-founded the National Adult Small Intestinal Transplant Forum and is an active member of a clinical reference group with the NHS in England, helping to develop a network within England for all patients with intestinal failure. Dr. Gabe has completed a doctorate degree as well as a master's in clinical nutrition. His academic and research interests include nutrition, home parenteral nutrition, intestinal transplantation, and intestinal tissue engineering. He will be, he will actually not be present giving us the presentation live. So excuse us if the presentation has a bit of hiccups, but because he couldn't be with us, unfortunately, his presentation will talk about nutritional aspects of functional gut disorders. And here we go.
So, hello everyone in Malta. I am delighted to give a talk here that Jeffrey has asked me to talk upon, which is the nutritional aspect in functional gut disorders. I gave him a few titles, and this was the one that he thought may be more useful. And as I look at this talk and I give it, I am aware that the nutritional element to this, which may be in fact the bit that you're most interested in, is rather minute at the end, and it's much more about the functional gut disorders than the nutritional aspects, but I try and weave it in as much as I can. It's not an easy topic, as everyone is aware of. But look, I hope you have a very good meeting, and I hope that this is part of it. To start off, I'm just going to start off a little bit about functional gut disorders. What do we mean by that? And I'll come on to more detail, but generally we think about an irritable bowel, and there's the Rome 4 criteria that have been developed over time. It's quite complex, and do look it up if this is something that is of interest to you. There's a paper related to that. Just look up Rome 4 and functional gut disorders, or IBS. You'll see there's a massive range. And if I'm going to really simplify this, you can sort of see when you look at an irritable bowel, you've got people who have got it's very common to have very mild symptoms of IBS. It's almost normal, I might suggest, in some respects. But the symptoms can become more moderate or much more severe. This talk is very much aimed at the very severe end. I'm sorry, I'm slightly in the way of the scale here, but it's not pointing at me, but it's at the very severe end of IBS. And these patients where you start to develop real nutritional problems that result in intestinal failure, those are the patients where this is either a functional problem, and sometimes there's an organic problem as well. Diagrammatically, also, to try and explain this, you've got sort of the severe end of IBS, and then you've got the severe end of then you've got the end of dysmotility. And I'm not entirely sure where the boundaries are within this, as I sort of indicate here a little bit. You've got patients with dysmotility who do not get intestinal failure. They may have problems, they have quite a lot, they're very symptomatic, but they maintain their weight, they maintain their vitamins and minerals that they need to be able to take in. They can be very symptomatic, they can have abdominal pain, vomiting, diarrhea, all these aspects, but they don't have an intestinal failure. That's what the IF stands for. But there are some people who have a severe dysmotility with intestinal failure, and those are the patients that are very difficult to manage. And this is functional because there's no clear mechanical organic cause for the intestinal failure that develops. The next question relates to, well, intestinal dysmotility, what is it? And the difficulty here is that there is no really clear accepted definition. Often we think about patients who have very functional symptoms from the Rome 4 criteria that I've described that may have a dysmotile bowel. For some of these patients where they've got vomiting or abdominal bloating and abdominal pain even. Sometimes you can make a diagnosis manometrically, where you take measurements of how the propulsion occurs within the bowel, and you'll make a dysmotility diagnosis. And you could do that at different levels. I'll come on to that: esophageal, gastric, small bowel, and potentially colonic. There's a radiological diagnosis, I'll come back to that, where you've got dilated bowel, and that's much more solid, but it's a subproportion of patients. And there's patients who might have neuromuscular disease, and that's histologically made and is on full thickness biopsies. What do we mean though as a definition? I'm sorry, I can't seem to change my position on the screen, but the definition that I've got here is where there's a severe digestive syndrome characterized by a derangement of gut propulsive motility. And the important bit here is in the absence of mechanical obstruction. So by default, there is no mechanical obstruction, but you've got some disordered propulsion that's occurring for these patients. One useful distinction that I'll come onto and mention quite a lot relates to chronic intestinal pseudo-obstruction, that's the CIPO, chronic intestinal pseudo-obstruction, versus an enteric dysmotility, ED. And with the pseudo-obstruction, these patients have radiological evidence of small bowel motility, which is useful. It's it's much more solid. And realistically, what we mean by that is that they have dilated proximal small bowel. And those patients with that, but there is no mechanical obstruction downstream, are a group of patients that I think that they're a subgroup of this group of patients. Equally, there are patients who have very similar symptoms. They may have nausea, vomiting, weight loss, abdominal pain, but they do not have a mechanical obstruction and they don't have dilated bowel. And that group you might call enteric dysmotility. So this slide here gets very complicated. So I've done it stepwise, but really it's just sort of all the key bit, take-home message is the number of conditions that potentially could be related to this, even though it's a very rare condition. You can have primary and secondary causes. If I focus on the primary causes to begin with, you're looking at myopathies, neuropathies, and mesenchymopathies. The myopathies to do with the muscles, neuropathies to do with the nerves, mesenchymopathies are to do with the connective tissues. And when you look also at the secondary group of causes, you could got myopathies, neuropathies, mesenchymopathies as well. And then you can have other things that are going on, like endocrine and metabolic causes, and even malnutrition itself can relate to dysmotility. Within the primary causes, here you go, there are some underlying causes that can be related to this, and for the secondary causes, again, a big list of potential causes. The group of patients that are becoming increasingly prevalent within this area are the patients with collagen diseases. Certainly in England, I think quite a lot in Europe. I'm not quite sure if you're getting this in Malta, but patients with underlying Ehlers-Danlos have an increased sensitivity of their gut. It's often associated with a whole load of other conditions, and they do seem to present at the severe end of functional gut disorders. Traditionally, these patients, when they've been losing a lot of weight, they're often young women. If they get put on parenteral nutrition, they don't do very well. And the key message is to try and avoid giving them parenteral nutrition where possible, and managing their conditions differently. When you're looking at the some of the groups that have been described, I've got ESPEN and I've got BAPEN here. Some of the data that comes up with the dysmotility. This is for patients with intestinal failure and dysmotility. So this is patients on intravenous nutrition support, and these patients are in a minority of the patients in nutrition support. In adults, you're looking at about 18% in the ESPEN group, and if you're looking at the BAPEN group, it's about maybe 12 to 15%. In children, it's a greater percentage, it has to be said. and that's where you can maybe get more congenital causes underlying this. It's worth looking within the ESPEN grouping here. This also, though, includes radiation enteritis scleroderma, which I may not put into that group necessarily. When you're looking at the pediatric group here, you can see over a period of time, this is going up to 2016, that the patients with short bowel, you can see increasing. The patients with neuromuscular diseases are maybe not quite so easy to see. It's the grey group here. And these are the ones with the pseudo-obstructions. And if you look at these bars, these have been increasing certainly over a period of time. This hasn't worked very well. I'm terribly sorry. But I looked at the group within St. Mark's. This is also going an equivalent period of time up to 2016. And this is for adult patients. And you can certainly see from the red bars, which is all motility disorders, really just increasing. The numbers are still very small on the left-hand side. These are numbers, not percentages. And then this is the patients with EDS, Ehlers-Danlos syndrome, just increasing over time. And we do still get this, the patients referred with these conditions, but we're much more careful now about trying to avoid enhancing their morbidity by giving them intravenous nutrition support. So the important bits when you're thinking about this subject is about conditions that might mimic or contribute to the presentation. First of all, you've got to be sure there isn't an organic obstruction, and I know that was in the definition to begin with, but it is actually worth sometimes just rethinking that through, even after a period of time. Jeremy Nightingale, my colleague who has now retired, did that for some of the patients that he took over at one point in time, and found a couple of patients who did have a mechanical obstruction that hadn't really been picked up. So it is worth thinking about. One of the problems is about opiates. Now, opiates, when patients have chronic pain, opiates are often used, and opiates will aggravate dysmotility within the gut. We all know that, but still somehow it still happens. And the problem then is when patients become opiate dependent, and they have their pain and they have their dysmotility symptoms, you don't know if opiates are causing it or enhancing it. Often it's enhancing, but nevertheless, patients need to come off opiates. This is something that has to be done in conjunction, usually with pain services. But the message really needs to come out about coming off opiates. Opiate antagonists can be used, and there are both oral and parenteral, as in subcutaneous, injections of opiate antagonists that are used and can be tried in this patient group, and I would encourage that where possible. But the other really important element is about psychological problems and psychosocial problems, and this is often a group of young patients, often female, who have got, you don't know whether they've got an eating disorder or either anorexia or atypical eating disorders. And the atypical part of it is that they don't have the body image disorder. They want to be a normal shape and size and see themselves as thin, but are very symptomatic, but nevertheless have lots of other features that would be consistent with an eating disorder. And this is important because you really, if you're going to manage these patients, however you're going to manage them, either nutritionally, physically, whatever it is, you need to do it in conjunction with a psychiatrist who they are seeing. And I'll come back to that. Importantly, within this group of patients, you've got this is a double peak. This is quite old data from going back to 1997, comes out of St. Mark's, and you've got the peaks from between 0 to 20, and then you've got a second peak in the 40 to 60 group of patients, which is interesting to see. And in the older group of patients, you do need to look for underlying malignancies that could be masquerading one way or another. In terms of the symptoms that patient gets, I've already mentioned bad abdominal pain, vomiting, nausea. You can see that within the pediatric group, I think they're just generally more symptomatic. There may be less constipation in the pediatric group and more constipation in the adult group. And diarrhea is is usually a much lesser feature for these patients. But these are the same symptoms often that you get in patients with quite severe IBS. There's constipation predominant IBS, diarrhea predominant IBS. So when you get IBS with weight loss and intolerance to oral and then enteral feeding, this is the group of patients we're starting to worry about. In terms of investigations, I mentioned a little bit earlier about that. It's obviously important to exclude mechanical causes. That used to be a barium follow through, often much more now CT or MR enterography. And you've got endoscopy and colonoscopy where appropriate. You can do motility studies, and that can be esophageal manometry. There's gastric emptying studies. But they are hard to do because often if these patients have severe symptoms and they're vomiting, you can't do the gastric emptying because they'll just vomit it. And you can't see how quickly the stomach empties. There are quite a few ways of trying to assess this, but I don't think there's any gold standard yet, realistically. Small bowel manometry is interesting, it's good, but it's not very available. It's very specialist, and also many patients can't tolerate it. Whole gut transit can be assessed very simply with some capsules, and there's anorectophysiology, looking at the very tail end. Full thickness biopsies on the histology side of things is, I think, quite useful. Sometimes you do pick up nerve disorders, muscle disorders this way, but often they're normal. The crucial bit, though, is that I think the histology needs to be looked at by someone very specialist. And even at St Mark's, we send ours to the Royal London, and because you've got one person in England who is the authority in this area. And I think, for example, from Malta, you would need to send off your histology if this is something for you that you're really considering. Oh yes, the final bit that I brought up here is it's essential to perform any functional studies of opiates or actually any other drugs that might affect motility. So sometimes it could be anticholinergics as well. And so that can be you might need to bring patients into hospital, get them off their opiates and offer any other appropriate drugs, manage their symptoms differently, and then do the functional studies. Here is quite a nice sort of, I suppose, movie almost of things that are developing. So small bowel MRI is usually a static picture, but if you take sequential pictures, and this is published now, but it's not normal practice. It requires quite a lot of imaging time, which in an MRI scanner isn't necessarily always available. But potentially you can look at areas that are more mobile than others, and there are equations to do that. As mentioned, this is published where you might find some areas where things are abnormal. In this study, for example, here's your control. You can see lots of activity that is going on, but this is the chronic intestinal pseudo-obstruction group of patients with dilated bowel, and you can see here there's one extreme where there's not a lot going on in terms of motility. Again, just simply showing the same sort of things in a graphical way. So it is possible to go along this route, but I think this is at the moment at a research level, it's not standard practice, but definitely I think will be coming to a theatre near you, as they say. It will be coming over time. Now, here is a study this and the next slides show some data from Salford in Manchester, which is the other large intestinal failure service in England. When you're looking at the diagnosis of these patients with dysmotility, often it's quite hard to understand if this is correct or not, if the diagnosis is correct. What was quite helpful, I think, in this study was to try and delineate some key criteria that need to be present if you're going to make the diagnosis. So they've sort of got A, B, and C criteria. The A criteria relates to symptoms. So many of these patients obviously would have symptoms, but then you've got to have one abnormal test, and then either a motility transit study that's abnormal or intolerance to small bowel feeding. Often this group of patients will have A and C, but you really want to hone in on some abnormal tests being there. So this sort of says full thickness biopsies, or there's transit studies being abnormal, or manometry being abnormal. So if you're using this, I think this is quite a useful way of trying to be sure that you are looking at the right patient group. When Salford did it, they had 52 patients in total, and when they did it, they noticed that 7 did actually not meet these pragmatic criteria, but another 45 did. And when they looked at that group of patients, they found that chronic intestinal pseudo-obstruction with dilated bowel was present in about 50% of these patients, which is interesting because certainly I think at St Mark's we would not get that. We haven't looked at it in such a way, but I think we've only got 1 or 2 patients with dilated bowel compared to maybe 20 odd or 30 odd who would be fitting into the non-CIPO group. This may be a little bit too much detail, but basically there are lots of different ways of assessing, and they went through this as you might expect, and plenty of the patients had different tests and different combinations. I think maybe the take-home message here is that small bowel manometry, certainly with CIPO, was really effective, and also the non-CIPO was very good. As I said, it's a very specialist test and not particularly available. But the important bit here is it's not tolerated by about 1/3 of patients. So sometimes the patients you most want to do this test in, you can't because they just can't tolerate it, which is really unfortunate. If I can move on, yes, okay. When they then looked at these patients, the two nice graphs on here. One is that there was no difference between the CIPO and the non-CIPO group in terms of cumulative survival over a period of time, of about 5 years or so, which is important. But the patients with this is actually people who stay on parenteral support. The CIPO group, the dilated bowel group, stayed on parenteral support, whereas the patients with non-dilated bowel were able to get off parenteral support, is what that graph is trying to elucidate. So I think it is quite useful to distinguish between non-dilated bowel and dilated bowel for patients with a dysmotility. So next, in terms of, that's all about diagnosis. How about managing them? Well, if you want to, 4 key parts to this is: one is ensure there's no mechanical cause, manage the symptoms, easy peasy, manage the nutrition and fluid balance, and address the psychological issues, easy peasy, and then you're all sorted. I've mentioned opiates. Avoid opiates. Avoiding parenteral addictive medication sounds entirely obvious, but we have found that many of these patients seem to like cyclizine, and that is really, really not good. There's good guidance now about avoiding parenteral cyclizine in the long term in patients. And the other bit is avoiding surgery, avoiding unnecessary operations for this patient group, which might sound obvious, but sometimes it's very hard to do. Patients with chronic constipation, plus all of these symptoms, might be suggesting that they want an ileostomy. And it might seem sensible, but our experience is that they have problematic stomas. and that you just change the problems from one set of problems to another, as opposed to helping them. With medications, prokinetics, there are lots of prokinetics that have been tried. You tend to find they're of limited benefit. Erythromycin, metoclopramide, domperidone, prucalopride are examples. Octreotide, we try not to use too much for this patient group. Neostigmine is like a big kit to the gut, has to be given in hospitals. And try and avoid that, it's quite hazardous. Antiemetics, ultimately I've mentioned about avoiding parenteral cytosine, and often we use it on ondansetron, but of course it can affect GI motility, and so that may not be a good one to use at the end of the day, and the usual ones often aren't that helpful. So you're trying to limit damage with some of these elements. In terms of pain control, non-narcotic pain modulators. Buprenorphine is an opiate, but it is an agonist-antagonist, so we tend to use that if possible, but it doesn't always work for patients. But avoiding anticholinergics and opiates has to be paramount in the management of this patient. In terms of diagnosis, I've got here about gastroparesis. You've got here a gastric emptying study with a flat line, when realistically what you would want it to do would be heading down this way over a period of an hour or so. Gastroparesis is common in this group of patients, and they vomit. So what can you do about it? Well, one of the thoughts is about venting gastrostomies. This was an area that we did some time ago at St Mark's. We still do place them, but much less frequently now, mainly because they come with problems. They are far from straightforward. They can be helpful to help stop vomiting, but the problem is that all PEG tubes are designed for feeding and not for venting, and sometimes they don't vent that well because of the position in the stomach, and equally sometimes you get problems relating to pain, to exit site infections, which are much more common in this group of patients. So can be used, but used with caution. If patients vent a lot of volume, then you can start to get into metabolic problems, because you're venting a whole load of hydrochloric acid ultimately, and you can end up turning one problem into another problem. Relates to chronic dehydration, and sometimes renal failure as well. And we have seen that as a result of chronic venting, or for patients when they overvent. Ultimately, I think we need better venting tubes, because, as I mentioned, they're designed for feeding, and there's a gap in the market here if anyone's feeling ambitious here. With respect to jejunal feeding, there are lots of different approaches. I mean, if you're trying to avoid parenteral nutrition in patients who are vomiting, then feeding distal to the stomach, and you think they've got gastroparesis, then it makes a lot of sense. Often we will try NJ feeding, and we will see if patients tolerate NJ feeding, because if the jejunal feeding is not being tolerated, then there's no point in going further down a pathway of putting in a surgical or endoscopic jejunal tube. But sometimes, obviously, if patients vomiting, it doesn't stay down too long. Nevertheless, it's worth trying and trying and trying to see if they can tolerate it, and can't underestimate that. Simple NJ tubes, very small caliber tubes. I'm not quite sure which ones you would have, but small caliber tubes that just go down without any gastric venting, and put them down as far as possible. If that, as a trial of therapy, and is working in terms of the patients being able to tolerate jejunal feeding at a reasonable rate and a reasonable caloric intake for them, then you can think about further tubes. There's the PEG-J going through the gastrostomy tube downstream, and if patients do already have a PEG tube, then that can be done without additional problems. But often those tubes flick back into the stomach and aren't good long term. And it's either a surgical jejunostomy or a direct PEG that is contemplated. There are advantages for both and disadvantages for both, and I've put them up on here. The surgical JEG can be laparoscopically done, but it's still more invasive than a direct PEG placement endoscopically. It's a surgical placement to remove, and the tube itself is made of silicone and has a limited lifespan. And so it tends to last about a year if you're lucky for some patients, occasionally a little bit more, and then you have to keep replacing them, and it's surgical procedures. And if you've got patients who've got dysmotile gut, you're going to be causing more and more problems. Consequently, we tend to like a direct PEG, where once you're placed under with a double balloon enteroscopy, it's a GA procedure, and then it can be replaced endoscopically. And there are pros and cons with all of these, but I won't get into it. Maybe this isn't quite the right forum. Ultimately, I think there's a need. Also, there's a market here for better jejunal feeding tubes to be developed, and maybe to take biopsies at the same time. Psychology, I've hinted at, but at the end of the day, this is a really important bit. Patients are very disturbed, either from the symptoms that they're getting or in conjunction, or even as a cause. There's often a background history when you start to probe, and you need to do this carefully. But when you start to probe for these patients, there's often an abuse history. It might be childhood abuse, it might be other trauma that's occurred in adult or young adult life, and it's extremely common. And basically, what I would say with all of this, if you only deal with the physical problems, you're dealing with only half the issues, and you can go further. If you only deal with the physical problems, you'll fail looking after these patients. You need to manage the psychology and the psychiatry together with the physical problems at the same time. So here, I'm sorry there's so little on nutrition support itself. This is much more about, it's been about tubes and about diagnosis. I'm talking about the severe end of this group of patients, and patients are often malnourished, and usually they're malnourished because they're not eating enough rather than they're not absorbing enough. They often feel as though there's something wrong with their gut absorption, but usually, if not almost always, that is not the case. There's not enough calories going in. You can try different things. Obviously, patients try get dietetic advice one way or another, and we might try low-fat, low-fiber diet. You'll try eating little and often, and changing meal patterns and all those sorts of things that we'd be trying to do. And sometimes that helps. And in the IBS group of patients, that often helps. The FODMAP diet, for example, causing less bloating, can be helpful, but the problem is the FODMAP diet is restrictive, and if you've got a patient who is already undernourished, that is an issue. You might go liquid with your diet for patients. If they've got poor gastric emptying, then liquids go through better than solids, and those are things with supplements, obviously, that are worth trying. That requires a patient who really wants to participate without having tubes putting them in, and that doesn't always happen. But those are definitely things that are worth trying within this group of patients. We've talked about placing tubes, and there's NG, NJ, or gastric or jejunal feeding one way or another through different tubes. There's the act of placing the tube, there's the management of the tube, but there's also what feed you might use, and it's worth always starting with standard feeds. You often, with this group of patients, end up going through different groups, different types of feeding, different types of feeds, depending on what's available. We often are using things like Peptamen or Vital 1.5, which are which have been broken down a little bit and may be better to tolerate. We tend to avoid elemental because realistically it's really not needed, and it's not necessary, and it tends not to be helpful. Parenteral support is often where we get involved in looking after these patients, and what we're trying to do is push them down the other end of them becoming more enteral rather than parenteral. But nevertheless, sometimes you do have patients who are profoundly malnourished, who you do really need to build up parenterally. And once they're built up, you might then retry some of the oral and enteral routes for this group of patients. And we have, in this group of patients, like with Salford, got patients off parenteral support. And that has always been good, because patients in this group who get parenteral support run into loads of problems. They have line infections, they have venous access issues, they have thromboses, they have problems with various tubes and lines, they have pain, etc. And it's really, really distressing for everybody in managing them parenterally. So some of the key elements here I've brought up on these boxes with food intolerances. Often patients do describe lots of different food intolerances, and you need to try and work within that, or even challenge some of these intolerances, and it needs experienced dietetic involvement. The gastroparesis element I've mentioned, and would be cautious about placing a venting tube. Jejunal feeding I've mentioned can be problematic, but it's sometimes a good way of trying to avoid parenteral support. And parenteral support has obvious risks, and try and avoid parenteral medications at all where possible. The psychological support is essential, and the next element is about working as a team. So that is the end of my talk on this, and if I am able to zoom in, I'll be very happy to take questions. Otherwise, I hope your day and your course goes very well in itself. All the very best, and stay safe, as they say nowadays. Goodbye.
Okay, so now we're going to the next speaker, who is Dr. Edward Despot. He's Maltese, but he's based in the UK. So Dr. Despot is a consultant gastroenterologist and an interventional endoscopist. He is the lead of endoscopy services at the Royal Free Unit for Endoscopy, Royal Free Hospital, and Honorary Associate Professor at University College London Institute for Liver and Digestive Health, interventional endoscopist whose special interests include device-assisted enteroscopy, endoscopic submucosal dissection, wide-field endoscopic mucosal resection, saline immersion therapeutic endoscopy, capsule endoscopy, and transnasal upper GI endoscopy. He is also interested in endoscopic diagnosis, characterization, and management of inflammatory bowel disease and related complications, including endoscopic management of small bowel and colonic strictures. Since his appointment as a consultant in January 2012, Dr. Despot instigated significant advances at the Royal Free Unit for Endoscopy by making it one of the busiest comprehensive small bowel endoscopy, including therapeutic, and ESD tertiary centers in the UK and in Europe. Dr. Despot is regularly invited to lecture and perform live endoscopy demonstrations at prestigious national and international meetings, including several in the UK, in Germany, in Brazil, and in Rome as well. He was awarded a bursary by the Japanese GI Endoscopy Society to present his work at the 85th JGES Congress held in Kyoto, Japan, and the British Society of Gastroenterology has also awarded Dr. Despot another traveling fellowship to Japan, where he underwent further training in an ESD and therapeutic DBE at the National Cancer Center in Tokyo and the Yichi Medical University, Tojiki, Japan, under the direct mentorship of Dr. Yutaka Saito and Professor Hironori Yamamoto. Dr. Despot, you're trying my Japanese here as well, respectively. In 2007, Dr. Despot received prestigious scholarship to undertake advanced endoscopy training at the Wolfson Unit for Endoscopy at Denmark Hospital and Academic Institute. He spent a total of 3.5 years dedicated endoscopy training at the Wolfson Unit at St. Mark's, during which time he also undertook formal research at the same institution and Imperial College London towards an MD research thesis entitled Advanced Minimally Invasive Aspects of Flexible GI Endoscopy. He continues to be actively involved in endoscopic research and currently forms part of the European Society of Gastrointestinal Endoscopy, the Guidelines Committee for Small Bowel Endoscopy, Quality Standards and Training Curriculum. He is also a co-author of ESGE Clinical and Technical Guidelines and the ESGE and UEG Quality Standards for Small Bowel Endoscopy. His presentation is entitled Minimally Invasive Endoscopic Management of Colorectal Polyps. Now, so, yes,
Thank you, Jeffrey. That's
you can
really,
go
really
ahead.
kind. I thank you for inviting me and also for the very
It's
kind
our pleasure.
introduction. And it's also a great pleasure of mine to be touching base with my home because although I've been here in the UK for the last 17 years, Malta is still very much in my heart and my mum still lives there and I visit often. At least I used to visit often before this crazy corona pandemic.
Yes,
And we
unfortunately,
live
yes.
in hope that things will move forward. So without much further ado, I'll talk about the minimally invasive endoscopic management of colorectal polyps. Although this is not your classical nutrition-related talk, it is still very relevant. And the invitation still makes a tremendous amount of sense given the fact that March is colorectal cancer awareness month. And we should really keep this in mind. And as healthcare professionals should always promote the need for preventive care and intervention, early intervention, because we know for certain that colon cancer can be prevented by a timely colonoscopy whereby we can find polyps and remove them in time before they morph into something nasty. So colonoscopy saves lives, and we all have a duty to push this forward. So very timely, and thank you for the very kind invitation. These are my disclosures. Right. So this is going to be a three-part talk. We'll talk about the quality of the procedure and lesion detection, because quality is key. If you do a colonoscopy without quality, we really are going to, be traveling on a fool's errand with not much ado, and it won't really be a life-saving procedure. So quality, quality, quality is key. I can't stress it enough. Then we'll move into the relatively simpler types of resection techniques, cold snaring, for example, where we don't use diathermy, polypectomy in its natural form, removal of a stalked polyp, and then we'll start going into slightly more complex things such as endoscopic mucosal resection, which is the removal of the flat lesions. And then for the really complex stuff, I'll talk about endoscopic submucosal dissection, which is the thing that I went to train over 5 times in visits to Japan. So we'll start off quality and lesion detection. You have to look, you have to find the lesion, because if you do not find the lesion, and by lesion I mean polyp or abnormality, you are not going to be able to save that patient from getting a cancer in the future. You need to find it, and then you make a decision about whether this is something that you can remove yourself as an endoscopist, or else whether you should refer to a tertiary center like ours where we can explore the more complex techniques, or else whether it is something that has already advanced to a stage where it needs an operation. And I'll talk about all this a bit later in the talk, but let's talk a bit more about quality and lesion detection. And quality, many a time, boils down to imperative basics. So the bowel preparation, you can have the latest scopes, the singing and dancing technology. If you do not get your bowel prep right, you're going to miss things, because obviously feces covering the walls is going to hide things. So this is the sort of mucosal appearance we're aiming for. Very clear, visible mucosal surfaces without the risk of these or any lesions getting hidden by feces. And if the bowel prep isn't right, you need to bring that patient again, because if you sign them off as having a relatively okay colon without any lesions, and the colonoscopy was done in the context of poor bowel prep, sadly, that is something that is false and should not be done. So if there's poor bowel preparation, they need to repeat that colonoscopy. Otherwise, that colonoscopy counts for nothing. And of course, even if there are patches of feces nowadays, we're fortunate enough to be able to wash them off. All scopes nowadays are incorporated with a special water jet channel. And these special water jet pumps, which are basically motorized pumps that shoot a water jet, much akin to the power wash of a car, of course gentler, and these are able to clean mucus away and wash away any residue in order for us to improve our ability to inspect in greater detail. And of course, one has to, again, go back to basics. Remember that gravity can help us. So if there is a puddle that needs moving and you can't suck it out because of some potential, residue such as seeds that can block the scope, of course, you need to give dietary instructions as well as the bowel preparation for patients to avoid eating things like that. But if that happens, you can shift it by changing the position. And with light sedation, because many a time we're able to do colonoscopy with light sedation, it all boils down to technique without causing discomfort to our patients, then of course you can shift things and you can improve the views. And that even holds when you don't have puddles of water or anything, and you just need to distend the colon better to be able to see. So position will help you and gravity will help you. And this is what we do. This is our sort of roadmap for turning patients to improve this. And then, of course, it's about optics and physics. So on the left-hand side, we have a standard definition scope, which we used until about, let's say, 10 or 15 years ago. And on the right-hand side, you have a high-definition instrument. And of course, you can appreciate the clarity of the picture. You can define the structures in a better way. And it boils down to the definition of high definition, because high definition or high resolution is the ability of an instrument to resolve two things from one big blur. So if there are two objects, they need to be seen as two objects rather than a blurred one. And this holds true for optics, microscopes, telescopes, and of course, our endoscopic instruments. So choose your best scope and invest in the latest technology if you do not want to miss things. And of course, we've traveled a very long journey, and we now have benchmarking and performance measures which allow us to aspire to a universal standard. And colleagues from all over the world have really appreciated the importance for benchmarking, because not every colonoscopy is the same. Not every endoscopist is the same. And we all have to aspire to excellence, because if one gets a colonoscopy, it needs to be rubber stamped with the stamp of excellence. Otherwise, again, it's not going to really be worth the paper it's written on, that report, because a falsely reassuring colonoscopy done with poor quality or poor prep is actually worse than not having a colonoscopy at all, because there's a degree of false reassurance. So we have to do those colonoscopies in a timely fashion but also in an expert and very high quality way in order to avoid patients getting colon cancer. And these are the quality measures. They obviously talk about the clinical findings and the way to get there, but also about the patient experience. It's not just about the actual procedure itself, but also about the patient experience. Remember, this is all about patient-centered care, which brings us to the Joint Advisory Group, which we're very lucky to have here in the UK as sponsored by the Royal College of Physicians. And this again is all about the patient journey. And it's not just about clinical quality, but it's also about the experience. So you give excellent quality care in the fantastic or the best possible patient experience that you can provide. And that relates to environment, interactions, comfort, etc., dignity, etc. All right, moving on to the technical side of things. I've talked about the water jet. You can also use something like Simethicon, which is a bubble breaker, easily available over the counter. Because bubbles, even if the colon is relatively clean, if you have bubbles, that can also obscure what you're finding beneath the bubbles. So we need to burst them, and we use surface tension agents such as Simethicon in order to do that. And of course, now we know that persistent mucus patches, especially in the right colon, may be a sign of an underlying lesion. There are things we call sessile serrated polyps or sessile serrated lesions, which in the past we thought were, innocuous, hyperplastic-like things that did nothing. We know now very differently that these lesions, although belong to the sort of spectrum of hyperplastic polyps, have a different route to colorectal cancer, which can be faster. So they sit there, they do nothing for a long time, not even have any areas of dysplasia in them, and then all of a sudden they change, and we discover this pathway, which is alternate to the adenomatous pathway. And these lesions produce mucus, and mucus can attract debris. So there'd be a patch there which you can't really wash off easily, and that is something that should draw your attention as an endoscopist to persistently look and then deal with that, because if you remove these in time, you again prevent a colon cancer. They tend to happen in the right colon and account for a significant number of these interval cancers between colonoscopies of dubious quality. Of course, you need to improve the visualization, as I said before, by changing position, insufflation, and looking behind folds with retroflexion in the right colon especially. And this is a publication relating to the serrated lesions I talked about earlier on, highlighting the fact that they're like snipers. These snipers put, twigs and leaves in their helmets to be able to camouflage themselves for the enemy not to be seeing them rather. And these things, of course, an analogy, can be camouflaged very easily because the mucus attracts a film of debris which may cause them to be missed. So you really, really need to look very closely for them. And they are very, very subtle and can be missed. And sadly, these things are like sleepers. They stay there for a long time without doing anything at all. And then all of a sudden they change into a cancer, and it can be poor prognosis. Of course, there are several things that have been developed over the years to try to look behind folds and move folds. But the bottom line coming out of the recent data is that if you have an experienced colonoscopist doing a very good colonoscopy and applying all the techniques that I've already described, they don't really add much. So it's all about getting the right training, making sure that you have the best bowel prep possible, using your best possible scope, taking your time and applying the best technique. The future, of course, I talked about the potential to miss lesions. We're very fortunate nowadays to be living in an era where we are adapting artificial intelligence to the likes of diagnostic technologies in medicine. And this is very much the case for endoscopy. So this is us using it in our unit where we have a processor that can analyze what you're seeing in real time on the screen. And if there's a subtle lesion, even a tiny one, the computer, the artificial intelligence machine gives you an indicator that there might be a lesion there, and of course there is a polyp which was subsequently removed. So this is there like a little guardian angel just in case the endoscopist misses something. And it's got a very respectable sensitivity and specificity as shown in papers, at least for detection. So moving on to the cutting phase of our talk. So removing polyps. So we'll start off with cold snaring, polypectomy, and endoscopic mucosal resection. And of course, for this part of the talk, there are some learning objectives to understand the lesion and the preparation and the setup, which is just as important as getting the skill set and knowing how to do it properly. We'll look at different techniques and then how to deal with complications, because everything we do can have its own complications. Marking for surveillance, because these things can recur, and of course we'll then summarize. So it all boils down to morphology, so you need to understand what you're looking at. And we convened in Paris almost, well, a very long time ago, almost 20 years ago. And in essence, we describe lesions in a very simple way, just to be able to speak the same language wherever you are in the world. And this is really important because a report should hold its weight wherever it is presented in the world, so that that patient can get a uniform care. This is a universal language. So it's very simple. It describes pedunculated polyps as an O1P, semi-pedunculated as an OPS, and so on and so forth, with S standing for a sessile lesion. And then you morph into the flat lesions, the ones that have a depression in the center, which can be nasty, very, very flat lesions, depressed completely, and then ulcerated. And these are the things that worry us most, because these are very likely to harbor things like already invasive cancers. And the reason why it's important to describe them is not just, to be speaking the same language, but also to understand the potential risk of that lesion morphing into a cancer soon, or whether it's already posing a great risk of submucosal invasion. Like, for example, this is a granular lesion, which is an LSTG in Japanese terminology, an O2A in Paris terminology. And a granular lesion of this sort is very unlikely to harbor any invasion, even if it is very large and carpeting. It is a puppy in comparison to this beast here, or this one, which are non-granular, so they're very flat and they're smooth. And this one in particular is depressed in the center, and the risk of submucosal invasion here can be even up to 70%, things happening and diving deep. For a lesion such as this one, which has a large nodule, the risk of invasion is going to be underneath this nodule, and it can be up to 10%. So it's important to understand morphology, not just to inform on strategy for removal, but also in terms of prognosis. And it's not just about the shape and the morphology, it's also about the surface. The surface speaks its own language. It gives us a lot of information about what's happening underneath. So Professor Kudo, a friend of mine from Japan, came up with this classification many years ago, and this still holds true, and it's still very respected and proven. So this is a normal pit pattern, and this is a hyperplastic or serrated pit pattern. This is a type 3S, which, although still low-grade adenoma, can move very quickly into this type of pit pattern, which is the dangerous one, type 5. This is a cancer or a submucosal invasive lesion. And these are other pit patterns for a tubular adenoma and the tubulovillous adenoma, respectively. And this is it in clinical practice when we spray a dives, for example, indigo carmine, and we use some zoom, because most of our scopes nowadays are equipped with near focus or a degree of zoom, close focus, for example, allow us to look and understand what's happening underneath the surface. This, for example, is a hyperplastic or serrated because it's got elongated star-shaped crypts, whereas this one is sort of elongated crypts, and this is a tubular adenoma with low-grade dysplasia. This one has a brain-like pattern, cerebriform pattern. This is a tubulovillus because you've got a villus component, slightly higher risk for high-grade dysplasia. This is the preemptive lesion, which moves very quickly to here, the 3S with the small round pits in the center, and this is dysmorphic pit pattern, which means there's already at least high-grade dysplasia, if not invasive cancer. And of course, it has a high sensitivity and specificity, which still holds true even many years later. Kudo pit patterns require a degree of staining, either with indigo, carmine, or crystal violet, which can be messy. So fortunately, most companies who manufacture endoscopes have come up with what we call virtual chromoendoscopy. This is nothing more than an optical filter, or sometimes with associated post-image processing by a computer in the processor itself. And by flicking on a button, you change the light into blue light, for example, and this allows us to read the surface even more. And this is the blue laser light imaging from Fujifilm, for example, or linked current imaging from Fujifilm as well. And it allows us to get similar information as we would get with the Kudo without needing to spray. So, for example, this one is a type 1 lesion via the JNet classification, which is the Japanese version of how we classify these, similar to the Kudo, but for narrow band imaging or blue light imaging. And this is a lesion that has an extremely low risk of having invasive cancer. This one is indicative of low-grade dysplasia, so it's a JNet 2A, whereas this one is very likely to have high-grade dysplasia because it's got some irregularity on the surface. And this is a complete mess, which would be a type 3 and deep submucosal invasive cancer. So by looking, we can understand. So this is still amenable to endoscopic resection, but the red box needs an operation. And why would it need an operation? Because even if there is a degree of submucosal invasion, it all depends on how deep. So the submucosa is the surface, it's the layer that lives beneath the mucosa, hence why submucosa. And we split it into tertiles. So SM1 means the upper third of the submucosa, SM2 is the second third, and SM3 is the last third of that submucosa. And this correlates heavily with the risk of lymph node metastases. So if you have a lesion that's already morphing into a cancer, but it's only SM1, the risk of future lymph node metastases is going to be very low indeed. So we still consider these for endoscopic resection. But when we move into SM2 or SM3, which correlates very much with what we're seeing on the surface, then you would be best to refer those for an operation. We also understand that even if a cancer is happening in a stalked polyp, the stalk is important because it provides you with an extra buffer zone of reducing the risk of future metastases, and this is the Haggett level. So we try to cut close to the bowel wall rather than close to the head of the polyp to give that buffer zone. The morphology of the lesion and the size and the site and the axis can also give us an idea of what we would expect when resecting the lesion. So looking at it is going to tell you whether you're more likely to have a complication doing that procedure and whether you need to take extra steps or not. And Professor Beck, who's also a good friend of mine from Sydney, he's done a lot of work in this regard, and he came up with what we call the Simser score, which is basically an evaluation of the nature of the polyp in order to predict most of the time risk of complications happening. Before we even consider resecting, always have a holistic approach. So keep your patient in mind. Not every lesion that can be resected endoscopically should be. You have to keep in mind the overall patient. So comorbidities, is this likely to really cause harm, this lesion, even if it is advanced? Or is it going to cause more harm to remove it and if we have a potential complication? Ablation is going to be critical. No endoscopy should be done using room air nowadays because carbon dioxide has been shown time and time again, not only to improve patient comfort, but also to improve safety. If you have a complication when you're using carbon dioxide, the chances of that patient deteriorating is going to be far less than if you were using air. Because if there is a perforation, for example, you're going to get a pneumoperitoneum with high pressure if air is being used. Whereas with carbon dioxide, that gas is going to get absorbed at least 200 times faster than air, and that allows for time to manage and more comfort. All right. You need to have your injection needles to raise that submucosa because many a time we inject into the submucosa before resection to protect the muscle layer and reduce the risk of a perforation. And you have to have the adequate injection solution in order to do that. And again, adrenaline helps in case there is some bleeding. Don't have just one snare. A snare is a wire we use to resect polyps with polypectomy, EMR, called snaring. So have a range. You need to have different sizes and shapes to be able to apply the right tool for the right situation. We also use coagulation forceps in case there is arteriolar bleeding, for example, using less and less now since our skill set has improved significantly over the years. And also clips, which would take you out of a tricky situation if you have an immediate perforation, for example, and we're able to deal with these things endoscopically, or even if you have acute bleeding. And always have a tattoo ready of sterile carbon particles because this thing is able to mark that area permanently. Number one, if there is an occult cancer, because as I said before, although you can get quite an accurate prediction by looking at the polyp and what's going on the surface, sometimes there is a cancer which would not have declared itself through the appearance of the polyp. And if that is the case, the patient may need an operation. And it would be so much better to have a tattoo there to guide your surgeon for a minimally invasive laparoscopic resection rather than not having that area marked. And of course, a tattoo will also allow for surveillance of that area, even if you are just doing a follow-up colonoscopy in order to look for recurrences in the future. The solution we use for endoscopic mucosal resection or raising the lesion off the muscle wall by injecting into the submucosa is many a time succinylated gelatin, in our case, gelofusum, for example, which gives you that time you need for it to stay lifted. We also put in a few drops of adrenaline to make a concentration of about 1 in 200,000 to create a dry field. And we also add a few drops of indigo calming just to give that blue stain in order for us to be able to appreciate the submucosal lift even more. And this is an array of snares, so it's not a case of one size fits all. You have to adapt your instruments according to the situation. And this is an example of the tattoo we use. This is the one that is most visible at laparoscopy. It's made by a company called GI Supply, and it's made really of a sterile suspension of carbon particles, which is inert. So as regards to any therapeutic principles, position is key. So you need to understand gravity, the dynamics, where the lesion is, and also what to expect should something to go wrong. We minimize insufflation because that stretches the bowel and makes it even harder to resect the lesion. And look as to where pooling is occurring because, for example, if you resect the polyp, it's going to fall into that pool of water towards gravity, of course, and if there's going to be bleeding, it's going to happen towards the area of gravity. So these things you have to do or consider before you resect. And we use a cap, a distal attachment, which allows us to keep slightly away from the lesion, but also to move forwards in order to achieve that technique even more perfectly. And this is what we use for cold snaring. This is a a specially designed snare, which acts like a pair of scissors. It quickly cuts, and a cold snaring can be applied to many lesions without the risk of significant complications, because many a time complications in resection are related to the diathermy, to the heat applied, because you can either have an immediate muscle injury or a delayed muscle injury. So if you are avoiding diathermy, then it is good to do so. Of course, not all lesions can be removed without diathermy. It all depends on size, because there's a limit to how much a cold snare can cut. But the sort of mark we go for is about 10 to 11 millimeters. So when we're resecting things, we like to bring it into the lower aspect of the field, so on the lower horizon of the scope. I like to inject a bit underneath the lesion, because even though with a cold snare you don't really have to raise it away from the muscle wall, just a drop of injectate allows you to catch more tissue around the lesion and get a clean margin, because the risk of a snare slipping as you close it and leaving part of the tissue there with future recurrence is going to be less. And it's important to crown the lesion, and I'll show you a short video with the open snare. And then you apply downward pressure, you ask your assistant to close the snare and cut, and then you can suck it into the scope. And if you've got a polyp trap ready, you can even get the polyp without having to, take out the scope, etc., etc. Then we always inspect the site and, if need be, apply clips. So this is a small sessile lesion, perfect for cold snaring, and you can see that it's a JNet 2A or a Kudo 3L pit pattern. We've injected a bit of fluid, slightly much there, but never mind, it never causes harm. And we're applying cold snare, downward pressure, I'm crowning it, I've got a good margin, and we've cut, okay, and then we'll suck the lesion into the scope, so that's it in, and that's gone to the polyp trap. I'll wash a bit, this oozing settles spontaneously, and there's absolutely no consequence, and that's a job well done. Clean resection, R0. Moving on to diathermy. So when you've got larger lesions, you need to apply heat, you need to apply electrical current, and before you use anything like this, you need to understand it well, okay, really. And for example, this is keeping most of the settings the same, but changing the effect. And the effect is really how much coagulation current goes through. And this is effect 4, so you can see this burn into this tissue being much more prominent than this one here. Okay, so we have to understand it. So simple polypectomy, when the polyp has a stalk, this is fairly simple. Of course, the risk here is not really going to be related to perforation. So this is the muscularis propria, and this is the submucosa. But many a time, stalked polyps have a big vessel going through there. So the risk many a time is relating to bleeding. Again, many a time we like it in the 5 to 6 o'clock position, although you still can resect at the 12 o'clock, and many a time we prepare the 6 or 5 o'clock position just because the instrument comes out of that zone. We tend to inject the stalk just in case there is a big blood vessel, in order to reduce that risk of very significant immediate bleeding that may cloud the field. And of course, you need to consider the Haggett level as I described, just in case there is a degree of invasion. So you cut closer to the bowel wall than to the polyp head. And this is another example. So we've got a tubular adenoma, tubulovillous adenoma in this case, with low-grade dysplasia. On assessment, we're injecting the stalk, that is the snare being used to crown the polyp. And we close the snare, as I said, about a third of the way up from the bowel wall. And when we're happy, we apply the blended current and resect. If there's a very large stalk, we like to apply what we call a polyloop or an endoloop, which is like a tourniquet which you leave there before you resect, and that reduces the risk of immediate or even delayed bleeding, and then eventually that falls off and the patient would be fine. So moving on to the flatter lesions. So when you've got flatter lesions without a stalk, you need to lift them away from the bowel wall, and that becomes much more important. The injection and lifting them away and resecting them. And in the past, before they realized that we can do this, all these patients with flat lesions ended up having major surgery. Now we can do most of this thing endoscopically without recourse to surgery. But you have to have the skill set. So for the smaller lesions, up to about 20 millimeters, we can still do this en bloc, so in one piece, as long as we get a good margin around them. And if they are very much larger than 20 millimeters, and if we are convinced that they only contain high-grade dysplasia, like, for example, the granular laterally spreading tumor that I showed you, then we can remove them piecemeal with wide field EMR. And there is an advantage to wide field EMR in that it is simpler to learn than endoscopic submucosal dissection. But of course, because you are removing it piecemeal, you may leave a few cells there, even with the utmost of precautions, and there is a higher risk of recurrence. So you need to keep these patients under close surveillance, because if they have a recurrence on an EMR scar, it may be a bit more challenging to remove because of fibrosis. You need to inject in a dynamic fashion. We tend to inject and resect. And of course, you cannot defeat the whole point of injection by injecting too much. The whole idea is to raise the lesion in relation to the background mucosa. So if you inject too much, you just raise a whole plateau and you're back to square one. Have a strategy, always take out the big nodules and do not leave bridges or islands. And of course, you need to cauterize the margin and use cold avulsion if there's any suspicion that you've left something behind in order to reduce the risk of recurrence. So this is another case whereby we're in retroflexion in the right colon. This is a sessile serrated lesion. You can see that mucus film, very subtle, can hide easily behind folds. So that's why we do retroflexion and we wash carefully. We're injecting underneath the lesion to raise it off the bowel wall, to raise it off the muscularis propria. And now this has allowed us to be retroflex. We crown it with a snare. We get a good margin around it. The submucosal injectate cushion is going to allow for safe resection, and that's off. And I'm burning the edges here just to make sure that if there is any potential tissue left behind, in this case, there is no evidence of that. And in this case, we're even clipping it shut because this patient was on anticoagulants. So there is always going to be a slightly increased risk of delayed bleeding. So it allows us to reduce that by closing it. This is a large lesion, which is a granular tumor, but it's got a large nodule. And this is a cartoon on the left-hand side demonstrating what we're doing in vivo on the right. So we're injecting underneath it. And the first thing I do is take off the large nodule, because as I told you, if there's going to be any nasty business, any invasion, it's going to be there, and we send it off separately. And then I keep on working, and there's a bit of bleeding, but that's not hindering me at the moment. So best is to carry on working and resecting it in as few pieces as possible. And once we resect this, so this is wide field EMR, we deal with the bleeding by placing a clip or two, and then leave well alone. So, and this patient, of course, because they've had a wide field EMR, would require closer surveillance. So we would repeat a procedure in about 3 months after this. And fortunately, there was absolutely no evidence of recurrence. So then we repeated a year later. We can also use underwater EMR as an alternative to injection underneath the lesion. Professor Ben Muller, a friend of mine from the west coast of the United States, invented this technique of immersion, initially with water. And this floats lesions, so it allows them to separate themselves from the muscularis propria. And he understood this when he was doing endoscopic ultrasound. So it can be used as an alternative, especially in the context of fibrosed lesions, and it's safe and effective. So it is an alternative. Moving on to complications. So as I told you before, the higher the Simson score, the more unfavorable things there are in relation to a lesion, the higher the risk of having a complication. So you need to predict these or try at least. And bleeding, perforation, and post-polypectomy syndrome are the most common complications we encounter. So I'll talk about bleeding. Bleeding can be either intra-procedural, and that's relatively easy to deal with because you've got a bleeding immediately after the resection, ready with clips, hopefully in the room. You can actually close it, stop it with clips or with some diathermy, or delayed. And this is the more worrying thing because if you've discharged the patient, they can have a big bleed in the middle of the night, especially in elderly patients with large lesions on the right-hand side, and you have to be vigilant for this. I always give them my personal mobile number just in case this happens. I tell them come straight Google free for an urgent scope should that happen, but they can be significant. This is a spurter during an immediate complication, but this can happen even with a delayed one. And we usually use mechanical means to actually stop it. How to deal with it? One should not panic. Always give attention to gravity because that is where blood is going to pool and change position accordingly. Have a water jet because that will allow you to clear the field. And the adrenaline may slow down the bleeding for you to apply more definitive means. And my good friend Tomo Noriano from Jichi Medical University in Japan developed also what we call gel immersion endoscopy. And he developed a gel which allows us to inject it into the lumen when you are encountering a significant bleed. And because gel is much more viscous than water, it does not allow the blood to mix with it very quickly. So you are using this like a glass pane or a pair of goggles. The blood does not enter into the gel. You can see through the gel, and it's sort of like seeing the blood bleeding in slow motion, and that allows you to pinpoint the bleeding point very accurately and apply definitive therapy. Because many a time in the context of significant bleeding at endoscopy or even at surgery, for all that matters, it's about the visual field. You just get a readout, so you don't really see. So you need to identify the bleeding point before you can apply definitive therapy. It's pointless shooting blunderbuss with clips or whatever. You need to pinpoint the bleeding source. And then you can apply hemostasis either by coagulation, so diathermy, or mechanical, or even using a coagulation forceps. And there are, especially in cases where we either want to prevent a bleed, you can apply what we call Purostat, which is a proprietary name for a beta pleated sheet. So this gel morphs into a beta pleated matrix, and that creates a sort of temporary scab while the body builds its own healing process, and that may reduce the risk of a delayed bleed. And we've also got hemostatic powders such as hemospray or endoclot, which basically allow aggregation of clotting factors, and we tend to use these when we can't stop the bleeding by normal means. Perforation, the dreaded one. So if it's immediate, many a time we can close it, okay. More dreaded is the delayed, because that one tends to require a big operation. So look for the signs of a potential immediate perforation or an imminent perforation. So the target sign, for example, is just a descriptive term that allows you to look underneath the lesion after excision. And if you see a central patch, so this was a large sessile serrated lesion I removed a while back, and lo and behold, you can see that there's a tiny patch in the center here, which means that part of the muscularis propria, even though not complete, has come off. And this is going to lead to a delayed perforation if you don't take action. So applying clips is going to be the way forward, and the patient will be fine. We tend to give them some prophylactic antibiotics. If something happens, especially if it's a full thickness perf, of course, don't panic. Shift fluid away by changing patient position. Give analgesia, minimize gas insufflation, because that's what's going to cause the irritation of the peritoneum. And then clip close, start from the lateral aspect. Don't go for the central part first, because it's easier to start from the left or the right. Give antibiotics, analgesics, admit and contact surgeons just in case. But many a time, we're able to deal with these endoscopically without an operation. Delayed is different. Delayed, you need to give analgesics and antibiotics, and more often than not, it's surgery because this is what you get. This is fecal peritonitis after a delayed perforation. You can see the diaphragm, and of course, this is the perforation site. All right, post-polypectomy syndrome, what is it? So this is focal pain because of localized peritonitis. It is non-perforating transmural irritation. You need to admit them, scan them, and give them antibiotics and clear fluids as required. And of course, one must not forget to tattoo. Many a time we tattoo distal to the lesion, always putting in saline first into the submucosa in order for us to be able not to cause spraying of that carbon particle into the peritoneum, because that would be not helpful to the patient in any way or form and would make surgery even more difficult. So we always make sure that the tattoo is placed within the submucosa. So this is us tattooing. So this is raising a submucosal bleb of saline and then switching to the carbon particles. You can see it going black in a second. And once we push in the carbon particles, then the saline gets absorbed and this is a permanent mark. So summary for this aspect of the talk, understand the lesion, refer if it's outside your skill set. Always consider the whole patient and not just the lesion. Use the most appropriate technique for the situation. Know how to deal with your complications. So my dear father used to tell me, before you learn how to use something, learn how to switch it off, okay? And before you use a new machine or a new piece of equipment, know how to deal with the potential issues before you even try. So that's critical. Always have surgical backup and don't forget to mark your resection site for surveillance. Endoscopic submucosal dissection, I'll touch upon this briefly because this is quite complex. So this is only relating to about 5% of lesions that we find. And of course, it is mainly where you want to remove a large lesion en bloc because you cannot remove it piecemeal with a snare, and it's too big for us to take it out in one piece with a snare without making a perforation. So endoscopic submucosal dissection is something we apply to certain situations. I'll tell you where, why, and how, and then we'll stop. So it's mostly relating to these lesions, either a large nodular lesion, because this has quite a significant depth of tissue, which reduces the ability of the surface to tell us the entire picture of what's happening underneath. When you have a depressed lesion, because the chances of there being something nasty happening, and of course the more advanced lesion. So this one would be absolutely okay to remove in piecemeal or wide field EMR. This one is ideally removed by ESD, but if you are going to use EMR, you need to send the nodule separately, and this one is going to be the ideal candidate for an ESD, and so is this one. Okay, you need to take them out en bloc in one piece and with a submucosal layer. So this is like microsurgery with the scope. So this is a lesion which we can easily remove in PCs, but of course, piecemeal EMR, as I told you, has its recurrence rates, which can be up to 20%. You need close surveillance, and if you have a recurrence, it can be very challenging to remove that recurrence if there's fibrosis. And plus, if there's going to be a degree of high-grade dysplasia or invasion, you do not understand where that might be, because it is like a jigsaw puzzle. So this would be best removed by ESD, the one on the right. And of course, we focus on the ones that have a low risk of lymph node metastases, because the higher ones would send you running towards surgery, because the risk is too high for later lymph node metastases. So we focus on those. And why would we try to avoid surgery? Of course, colorectal surgery has significant risks, which when one considers age, can be very, very significant, particularly for over 70-year-olds, and a 1-year mortality for an over 80-year-old having colorectal surgery can be up to 29%. So colorectal surgery has significant risks, and these are the risks relating to this, okay? sepsis, bleeding, anastomotic leaks, and recovery. So where we can avoid surgery, we should. Which brings us to ESD. This is a technique developed in Japan, hence why the samurai sword. And we aim to take out things en bloc by cutting underneath the lesion. You need to carefully evaluate the lesion. You need to select your patients very, very carefully, as I said. Have a tumor board, a discussion of the MDT, and always have appropriate consent where you explain risks and alternatives too. These are the instruments we use. These are knives used for ESD. We all have our favorite ones, and these are mine. So we tend to use a needle knife that we can inject through, such as the flush knife or the dual knife. And we also use a special hood, which we attach to the tip of the scope to enable us to dive underneath the lesion. And I'll show you a short video of this. The injection solution we talked about before, in special settings on the diathermic machine. And this is how we do it. So we inject underneath the lesion, we make a tiny cut here. We dive by dissecting the submucosa underneath the lesion with a knife. And once we've undermined the lesion completely, we open the pocket. And this is our favorite method, the pocket creation method as developed by my great mentors in Jinshin Medical University in Japan. And that gives you a surgical specimen that you can send to the lab. The advantages of the pocket creation method of ESD are that it maintains a thick submucosal layer, so the histopathologist can tell you whether it's SM1, SM2, or deeper. And of course, keeping the cut relatively small by undermining keeps that fluid in the pocket, which allows you to have a better and more efficient dissection. And it keeps you parallel to the muscularis propria, which means the risk of a perforation while cutting is minimized. And it also enables you to avoid the artifactual and disturbing movement of breathing, because if the scope is inside the lesion as you are removing it, you eliminate that disturbance of breathing, okay, the movement of the diaphragm. We need a special hood, as I said before, and this is us doing it with the hood into the pocket and cutting underneath the lesion. We took it a step further at rule 3. We developed something called SITE, which is saline immersion therapeutic endoscopy facilitated pocket creation method. And what we do is we don't use gas, we just switch off the gas, we switch off the CO2 and use saline instead. And saline tends to float the lesion. It also enhances cutting and it improves the visualization. It gives you this sort of zoom as if you're underneath the water wearing your goggles. And you can see why it helps with buoyancy, okay? It floats the lesion very much like this.
I am currently reading a degree in Facilitating and Adapting Education at MLI.
Qed nagħmel kors fuq l-inklużjoni, qed nagħmel degree.
It has been a wonderful experience. We have had so much positive reinforcement from our tutors.
MLI is a very good institute in Malta, and I have a chance to be as a healthcare professional here.
My experience at the Malta Leadership Institute has been very enriching. In terms of the content we are taught,
L-esperjenza tiegħi dwar din l-iskola hija waħda pożittiva immens.
All the teachers and the lecturer, they are very good, cooperative, and they are giving the information very informative.
They have been there for us all the way.
the lecturers are always very, very helpful.
The way of teachings are highly professional.
Dejjem insibuhom lesti biex jgħinuna u jissapportjawna f'dak kollu li jkollna bżonn.
They are always there ready to help us with any concerns we have.
I totally recommend this institute, especially to all those who perhaps feel that maybe we are too old to actually start studying again.
For further information, you can visit us at maltaleadershipinstitute.com or else contact us on our email below.
Teaching is our passion, learning is our concern. Start your journey at Malta Leadership Institute.
Let us continue with our presentations. And now we have a short promotional session which is going to be carried out by Miss Mirjana Borch. and she is a representative of Nestle. She will be giving us some information herself. Welcome, Ms. Borch. So it is up to you. Thank you.
Hi everyone. So yeah, thank you for the invite and for the time, Jeffrey. My name is Mariana. I started out my career as a nurse at Mater Dei Hospital. So I worked in surgical areas and in anesthesia. But last November, I joined Nestle Health Science as a medical rep. And today I'll be talking to you about Meritin. So I'm just going to share my screen here. So let me know if you can see it. Give me a second. Perfect. So now you should be seeing the
Yes,
presentation.
yes.
Yeah.
Okay. Thank you. Yes.
So yeah, Meriton is a range of products that Nestle has developed to support healthy aging. As we all know, our life expectancy is getting longer and the mortality rates are getting lower, which means that our population is aging rapidly. But despite the fact that this longevity is incredible, it has essentially become a health concern and a societal concern. So as people enjoy longer lives, the main challenge now is to maximize the potential for those extra years to be healthy, to have a good quality of life, and really to minimize the disease and dependency. So that is exactly what Nestle is trying to achieve. Our motto in general is that we want to empower healthier lives through nutrition. And given that aging, is a multifaceted process which has several factors affecting it, mainly there's the loss of function in cells and tissues and an increased risk of disease. Nestle has given this a lot of importance, especially because there's a lot of studies that show that specific foods and dietary patterns, along with some extra curricular activities, can really improve the quality of life with aging. And this is what we're trying to do with Meriton. So we are trying to achieve this kind of better quality of life for healthy aging, because despite all of our efforts, aging is expected to play its part. And we're expected to see a decline in muscle mass and bone mass, a reduction in articular cartilage, atrophy of the skin epidermis, overall degenerative changes, and frequent fatigue and decreased strength. So, what I'll be doing today is I'm going to go through some of these challenges of aging and just kind of show you how our products are helping to improve their manifestations. The first thing I'd like to discuss is the effects of aging on muscle mass. So, as we age, we're expected to lose muscle mass and strength, and this concept is known as sarcopenia. Now, researchers have studied this very well, and they've noticed that sarcopenia is mostly prevalent in the seventh decade of life, and it's really quite surprising that at 70 years, individuals will lose up to 10% of their muscle mass with every decade. So with every 10 years, they lose 10%. And in parallel with that, the strength declines with 10 to 15%, which is really, really drastic. And to make it all worse, it does accelerate after 70 years. So it accelerates up to 25 to 40% decrease. And with all that, we have a very nice play of, decreased physical activity, lower hormone excretions, nutritional deficit, and they kind of all come together to create this complex body challenge. And if we look here, what we will see that there is actually a really good way not to prevent this, but we can kind of minimize and slow down the progression of these expected changes. And the first thing that is really, really important is actually exercising. So the the skeletal muscle is a highly plastic organ, which makes it very, very easily adaptable to its environment. And of course, staying active has several other benefits. So it improves cardiovascular health, which in turn improves the rest of the body functions. But everything is not that simple, and exercise alone won't do much. Because sarcopenia, as I mentioned, is a very complex process, and interactions of hormone levels and nutrition play a very major role. So the next thing we'll be looking at is how the nutritional needs change with old age. Because most studies suggest that older adults require a higher nutritional intake since they are at an increased risk of malnourishment and morbidities. And it's also believed that the nutrient intake in older adults is compromised by general decline in body mass, basal metabolic rate, and decreased energy requirements. However, despite this need for a high nutritional intake, most elderly will not consume enough food. And this is related to a lot of factors. There's a decrease in appetite, there's a change usually in their smell or in their taste. A lot of the elderly people, they do live alone, and if they're just by themselves, they have no motivation to cook, or they don't know how to cook. And lastly, they're usually experiencing difficulties with eating regarding to their teeth, or gum problems or swallowing problems. So given that most of the elderly do not consume enough food, they are very susceptible to developing deficiencies in different nutrients. So, as we can see here, deficiencies in different vitamins and minerals will have different symptoms. For example, we have a deficiency in protein, which will result in decreased muscle mass. A reduced level of vitamin D will decrease bone density and increase fatigue. A lack of vitamin E increases oxidative stress. We can see that deficiencies in vitamin C, B3, and B6 increase frailty, muscle pain, fatigue, and apathy. And issues with vitamin B12 create a high risk for neuromuscular problems and a decrease to exercise tolerance. And then we also have the minerals here. So, reduced calcium levels will make individuals more susceptible to osteoporosis. We can see that a decrease in selenium creates a risk of muscular dystrophy. Low levels in magnesium create decrease in glucose availability in the brain, in the muscle, and the blood. And lastly, we have iron deficiency, which will cause a low resistance to exertion. So, in order to fight all of this, Meriton has developed a range of products that are packed with specific vitamins and minerals to support our nutritional needs as we age. And these products, really and truly, are not only aimed for the elderly, but we have quite a few products that are also aimed at adults over the age of 50, because studies have shown that over the age of 50, still there is a slight degree of decline in our body's nutritional needs. So, the first product I'd like to discuss with you is Meritan Mobilis. And Meritan Mobilis is specifically designed to support the joints, the muscles, and the bones during exercise and daily activities. It contains six vitamins and seven minerals, and it is specifically has vitamin C, which aids collagen formation. It supports cartilage. There is calcium to sustain bone mass, vitamin D to aid in the absorption of calcium, and protein to maintain muscle mass. And along with all this, Meritan Mobilis also has hyaluronic acid and hydrolyzed collagen to support elasticity. Now, Meritan Mobilis comes in vanilla flavored sachets, and they can be mixed with water, with milk, with yogurt, or if you're feeling, a bit frisky, you can always add them to your recipes. Ideally, you would take one sachet per day for a minimum of 8 weeks to see the full benefits of Meritan Mobilis. And of course, this has to be in conjunction with a balanced diet and a healthy lifestyle, because in no way are our products a meal replacement. They are simply there to support our daily intake. The next product that we have is Meriton Strength and Vitality, which has, let's say, a broader range of nutrients, and it's ideal for adults who are recovering from illness or surgery and who require additional nutritional support. So, any adults who are suffering from fatigue, who are at risk of malnourishment, or who simply want to add or need extra nutritional supplements can use Meriton. And the best thing about this is that it has absolutely no side effects. So it is perfect for individuals who are taking a lot of different medications. It comes in three flavors. So we have vanilla, chocolate, and neutral flavors. Again, it can be mixed with water, it can be mixed with yogurt, milk, or recipes. And it is recommended to take one sachet per day, ideally either the start of the day or in between meals, because it works better when taken on an empty stomach. And then we have, I think this is my personal favorite, Vita Choco. It's something a bit more for the younger adults who are on the go. Vita Choco is basically chocolate tablets, Swiss chocolate. So they are not only tasty, but they are packed with 5 minerals and 12 vitamins. They come in dark or milk chocolate, and they are aimed to reduce stress, they support the immune system, maintain bones and teeth, and they reduce oxidative stress. Ideally, the Meriton Vita Choco is taken around 2 to 3 tablets per day, and each tablet contains less than 30 calories. So you won't feel guilty about eating chocolate, which is really good. Then we have Meriton magnesium and potassium. So this is aimed for individuals who require perhaps a higher intake of magnesium and potassium. It comes in a citrus sachet, and apart from that, it also has selenium and vitamin C. These sachets are packed with resveratrol, which is an antioxidant, and it has been shown to lower blood pressure and cholesterol levels. It also has lutein, which supports the macula and the retina in our eyes, and the coenzyme 10, which has been shown to reduce symptoms of angina and chronic heart failure. Lastly, then we have Meriton fiber. So Meriton fiber is based on partially hydrolyzed guar gum. And PHGG is a natural dietary fiber. It's a water-soluble white powder which becomes colorless and transparent once it's mixed. PHG is also stable and soluble at various pH levels, which are commonly found in foods, as well as resistant to heat, acid, salt, high pressure, and digestive enzymes, which means that you can really and truly mix it with anything. It can be mixed with tea, with soups, with water. So it's very convenient. It can also be mixed with thickeners. So in people who do have dysphagia, who do have problems with swallowing problems, it can be mixed with thickeners. And our Meriton fiber helps to regulate the bacterial flora and improve intestinal balance. It reduces abdominal pain and discomfort, and it reduces the accumulation of flatulence. It is recommended to take 1 scoop of 5, which is 5 grams, in 200 mils of liquid per day, and it can be increased to 4 scoops a day, depending on the individual's needs. So those are all of our products. Perhaps I'm not sure if someone is interested in any particular products or has any questions, but if you are, feel free to email me or just contact me through my phone. I'm more than happy to give you any samples. Would anyone like to ask any questions about any of these products? Okay, I think we're all good, Jeffrey.
Thank you. Thank you. Very informative.
Thank you.
Thank you. So now we've got another promotional session of our other sponsor. Can you stop sharing the
Yeah.
presentation, please?
1 second.
Just stop sharing. Stop. From the bottom.
Okay.
Yes, that's it. Thank you. Now we've got a promotional message from our other sponsor, who is Metropolis Pharma. Okay. They are, well, as I said before, they have been our sponsors for a number of years as well. And so we shall see the presentation which they have sent us. They have sent us a video, which I will show you now soon. So.
Billions of bacteria in our gut. Sometimes the symptoms can be. Good morning. This brief presentation is going to be about the use of probiotics in certain health issues, and I will be focusing on result in health issues. Sometimes the symptoms can be minor, but sometimes they can be quite severe. What causes dysbiosis? This can be caused by medication such as antibiotics, poor diet, travel, stress, aging such as menopause, and others. What are the symptoms of dysbiosis? When our gut bacteria is out of balance, our body is unable to digest food the way it's supposed to, and this leads to discomfort which is generally gut-related. Symptoms such as diarrhea, sluggish or irregular bowels, bloating, indigestion, food intolerances, IBS and IBD. This imbalance can also lead to other symptoms such as thrush, allergies, eczema or acne, and low energy levels. Now, probiotics can help balance the gut with plenty of good bacteria, thus helping us keep healthy and avoiding such issues. Sometimes we also hear of prebiotics. These are basically non-digestible foods which stimulate the growth and activity of bacteria. In probiotics, they can be found as inulin, oligofructose, galacto-oligosaccharides, fructo-oligosaccharides, and others. How should probiotics be taken? The best time to take a probiotic is in the morning with breakfast. This is the time when stomach acidity is more neutral, and this could ensure the highest survival rate of your probiotic. Capsules should be swallowed with a cool drink, or the contents of the capsules or sachets can be sprinkled in drink or on food. We also generally recommend that probiotics should be taken away from antibiotics, that is 1 to 2 hours after. What should one avoid? We should avoid heat, that is, do not sprinkle powder directly in a hot drink, and also acidity, such as orange juice. However, hot drinks may be consumed directly after taking probiotics. This is a range of 14 products which target different issues. They contain live cultures of strains of the highest quality, and some of the products also contain prebiotics. They are very well researched and have over 200 clinical trials, both on individual strains as well as on finished product. They are all free from gluten, nuts, sesame, and other allergens. Most are vegetarian as well as vegan. The strains are carefully chosen to formulate a specific product for specific conditions. Today I will go through just a few of these products in detail. One of the most popular is Optibac Everyday. This has both live cultures, 6 different strains, as well as prebiotics. It has 5 billion bacteria, and this is a product which we generally recommend to help healthy digestion, boost immunity and energy levels, as well as for mental health. The dosage would be 1 capsule daily. One of the most frequent gastrointestinal conditions we encounter is IBS, especially that triggered by stress, which unfortunately is quite common in these times. Typical symptoms include abdominal pain and bloating, cramps, diarrhea, and constipation. A number of Optibac products are found to be very useful in alleviating these symptoms. The most popular is Optibac Extra Strength. This has 20 billion bacteria and contains 4 strains of the highest quality, in particular Lactobacillus acidophilus NCFM, which is the most well-researched acidophilus strain, with over 45 clinical trials. It has been shown to have great potential in reducing bloating, pain, and discomfort. In one particular study, 73% and 62% of participants saw an improvement in bloating and abdominal pain and cramps, respectively. Next we have Optibac Max with 50 billion bacteria. This contains 3 strains, including Lactobacillus acidophilus NCFM, as well as Bifidobacterium lactis HN019, which has been shown to have anti-inflammatory activity. In fact, in one particular study, after only 14 days of probiotic intake, the participants saw a substantial improvement in a number of symptoms associated with IBS. These included pain, diarrhea, constipation, flatulence, and others. We usually recommend this product at the beginning of treatment or during flare-ups. Now here I have presented these 3 everyday products in a table to facilitate understanding the differences. First, you can see the number of bacteria. So everyday has 5 billion bacteria as well as prebiotics, the FOS. Extra strength has 20 billion bacteria and max has 50 billion bacteria. The 3 of them are gluten-free and vegetarian. Extra strength and max are also vegan, whereas everyday has traces of dairy. This is the recommended age. We can actually give everyday and extra strength from 1 year up. The max, however, can be given from 4 years up. Obviously, the capsules can be opened. Finally, this is the uses of each product. So everyday would be used for general gut health as well as mental health. Extra strength is the one we would recommend for those with digestive issues, such as IBS and diverticulitis, also those on long-term antibiotics. And max would be the product to recommend for those wanting a powerful probiotic, such as during flare-ups or at the beginning of treatment. As we mentioned earlier, IBS is associated with a number of symptoms. Bloating and pain are the most common. However, some sufferers also get episodes of diarrhea and others get episodes of constipation. A number actually get mixed symptoms. Optibac also has products which target these 2 symptoms. Saccharomyces boulardii. This is the only yeast which is a probiotic. Its main use is in the treatment of diarrhea, including that associated with IBS. The dosage is generally 1 capsule morning and evening. However, in cases of acute gastroenteritis, it's very useful as increasing the dosage to 6 capsules in the day can give very fast relief. In fact, it is recommended to take 4 capsules together on onset of diarrhea, followed by 2 after a few hours. Generally, symptoms subside quickly, and the dosage can then be reduced to 1 capsule twice daily for the following days. It's useful to note that this is also available in packs of 80 for those people who use the product long term, as in IBS. So this can be added to Optibac Extra Strength or Optibac Max during these episodes of diarrhea. On the other hand, for those suffering primarily from constipation, we have Optibac Bifidobacteria and Fiber, which is an excellent product that can be used both to maintain regularity as well as to increase bowel movements in those who tend to have sluggish bowels. These are sachets, and they contain just 1 strain of bacteria, Bifidobacterium lactis BB12, which has over 135 clinical trials, and it also contains 4 grams of FOS, of prebiotic. So how does this product work? It colonizes the colon. The Bifidobacterium feeds on the FOS and produces short-chain fatty acids. This is an oily-like substance which lubricates the colon, allowing easier passage of the stool, as well as energizing the smooth muscles to promote regulated peristalsis. So this is not your average osmotic or stimulant laxative. such as lactulose or Senokot. Therefore, it is not dependency forming and does not carry the risk of cramping. I would recommend you consider this for your patients with IBS who tend towards constipation, and also any elderly patients with constipation. Again, dosage depends on severity of symptoms, with 1 sachet a day for maintenance and up to 4 daily for stubborn constipation. So here I've done a little summary of the products that are used in the treatment of IBS. So for mixed symptoms, one would use either extra strength or max. This is going to support general gut health. The choice depends basically on the severity of symptoms, and the dosage would be 1 capsule daily. For those with episodes of diarrhea, one would add Saccharomyces boulardii 1 capsule twice daily. And for those who suffer from constipation, we have Bifidobacterium and fiber sachets, which would support regularity. 1 sachet for maintenance and up to 4 sachets spread out during the day for stubborn constipation, which can then be tailored down as bowel movements improve. Another product which is very popular in our range is Optibac 1 Week Flat. Bloating is a very common symptom and affects about 30% of the general population, particularly those suffering from intolerances to certain foods, such as starch and lactose. These patients are deficient in the enzymes which break them down. 1 Week Flat sachets combine 4 strains of bacteria as well as prebiotics. These strains have the ability to produce the enzymes necessary to digest starch and lactose, thus reducing symptoms such as flatulence and bloating. The sachets contain a flavorless powder that can be sprinkled onto food or drink. They can be taken either as a 7-day course or even as a long-term treatment. Now, for completion's sake, I'm just going to mention briefly the rest of the range. We stated at the beginning that antibiotics are one of the problems faced by our gut microflora. Optibac has a specific formula called for those on antibiotics. There are 18 clinical trials where this product has been taken alongside a course of antibiotics and shown to reduce side effects such as antibiotic-associated diarrhea. The pack contains 10 capsules, so it is intended for those on a short course of antibiotics. We also mentioned earlier that probiotics should be taken 1 hour after an antibiotic. This is not the case with this product, because this can be taken at the same time. So you have the advantage of being able to take it at the best time of the day, in the morning, with your morning dose of antibiotic. And the dosage would be just 1 capsule daily for the duration of the antibiotic and a few days after. Optibac for women, this is actually our most popular product, and this is specifically formulated to support balanced and healthy intimate flora. It is suitable for the treatment and prevention of vaginal thrush, in particular the thrush that sometimes results after antibiotic use, as well as cystitis and urinary tract infections and bacterial vaginosis. For kids, we have 2 products. We have Optibac for baby drops, which is recommended from 0 to 3 years. This is particularly useful to reduce the risk of colic and allergies, as well as to boost immunity. They can even be used directly, placed directly into the baby's mouth or mixed with the milk. And we also have Optibac for babies and children sachets. Now, this is also recommended from birth, but can be given up till 12 years of age. The sachets can be mixed with milk, water, or sprinkled onto some food such as cereal or yogurt. It is especially useful to maintain good gut health and also to boost immunity. Then for adults, we have for daily immunity. This contains 5 billion Lactobacillus paracasei casei 431. Again, this high-quality bacteria has over 20 clinical trials, including a gold standard trial with over 1,000 participants. This was shown to decrease duration and severity of illness. It also has added vitamin C. This was obviously very popular this past year. Then we have Optibac for your cholesterol, which is excellent for those people whose cholesterol levels are borderline or for those who wish to reduce their dosage of statins. It has 1 capsule of probiotic and 1 capsule of omega-3. The omega-3 is alpha-linoleic acid, so it comes from a plant source. The product reduces the production of cholesterol in the liver, as well as the absorption of dietary cholesterol. Both capsules are to be taken together in the morning. Finally, this is our last product. It was launched just a few months ago, Optibac for pregnancy. This is for our expectant mothers and is recommended from conception to 6 months after delivery. It is well known that during pregnancy the microbiome changes, and this brings about a number of symptoms, such as bloating, nausea, constipation, and vaginal infections, as well as other risks, such as gestational diabetes and postnatal depression. This product has strains which have been shown through studies to reduce these symptoms and risks. Thank you very much. If you have any queries on the Optibac range, please visit us on Instagram or on our Facebook page, Optibac Probiotics Malta, and feel free to message us. You may also be interested in visiting the Optibac website, www.optibacprobiotics.com/UK, where there is loads of information and some very interesting articles. Thank you.
Hello, ladies and gentlemen, and welcome to my presentation entitled Lifestyle Changes Promoting a Healthy Gut. During the course of this presentation, we will be addressing key aspects of the importance of maintaining a healthy gut. We shall start by outlining the key functions of the digestive system and nutrient absorption, and understand why the gut microbiota is so important for gut health. We will also be looking at the relationship between our gut and our immune system and answer the question as to why is the gut is important to have a healthy immune system. So let me start off by outlining the primary function of the digestive system. That starts off at the mouth, where the food is first broken down manually by our teeth and mixed with salivary enzymes to kickstart the digestive process. Food then goes down the esophagus by the help of peristalsis and is released into the stomach. Here the food is mixed in with hydrochloric acid and stomach enzymes to digest the proteins and other nutrients, and eventually, with the help of the stomach's churning motion, becomes a liquid form known as chyme. The chyme is then delivered into the small intestine, and this is where absorption and intake of nutrients starts. The stomach has 3 main functions. The primary function is temporary storage for food, which passes from the esophagus to the stomach, where it is held for 2 hours or longer. Mixing and breakdown of food by contraction and relaxation of the muscle layers in the stomach, and digestion of food. The mucosa contains specialized cells and glands that produce hydrochloric acid and digestive enzymes to help digest food. The stomach does not play a big role in absorption of food. It only absorbs water, alcohol, and some drugs. The pancreas, liver, gallbladder, and bile duct all play their part to aid in digestion. We know that the pancreas secretes digestive enzymes into the small intestine, facilitating the breakdown of proteins, carbohydrates, and fats. The liver produces and secretes bile into the gallbladder, which is slowly released to break down dietary fats, and in turn, the small intestine delivers the carbohydrates, fats, and nutrients into the liver, where they are converted into protein and glucose to fuel the body. Once the small intestine is done absorbing nutrients, the remaining chyme moves into the colon. Here, water and electrolytes are absorbed, and the leftover solid waste is eventually eliminated through the rectum. The main functions of the small intestine are secretion and absorption. The epithelial cells of the small intestine secrete enzymes which digest chyme into the smallest particles, making them available for absorption. Concurrently, the duodenum functions to mix food with bile and pancreatic enzymes to continue the digestion of carbohydrates, fats, and proteins. Concerning absorption, carbohydrates and proteins are absorbed in the duodenum and jejunum, respectively. The jejunum also functions to absorb most fats. The ileum function involves absorption of vitamin B12, bile salts, and all digestion products which were not absorbed in the duodenum and jejunum. All three small intestine segments absorb water and electrolytes. The large intestine is responsible for several major functions: absorption of electrolytes such as sodium, potassium, and chloride, and water, propulsion of intestinal contents, and deformation, temporary storage, and defecation of feces. The large intestine houses the physiological microflora, which is rich in anaerobic bacteria that live in symbiosis with the human body. They fulfill essential functions such as decomposing indigestible food ingredients, producing vitamin K, promoting intestinal peristalsis, and supporting the immune system. The gut flora, also known as gut microbiota, are the microorganisms such as bacteria that live in our digestive tract. We are all born with a sterile gut, and gut colonization starts at birth, through the birth canal. By the age of 2, our bodies would have developed a mutualistic relationship with our gut's flora, resulting in several benefits. Certain microbiota have a major role in strengthening gut integrity, shaping the intestinal epithelium, harvesting energy, protecting against pathogens, and regulating host immunity. Other bacteria have the ability to ferment the dietary fiber found in complex carbohydrates and turn them into short-chain fatty acids, which are then easily absorbed by our bodies. Moreover, the GI microbiota are crucial for the production of essential vitamins which our bodies are incapable of producing. For example, lactic acid bacteria produce vitamin B12. Bifidobacteria are the main producers of folate, a vitamin involved in the crucial host metabolic processes including DNA synthesis and repair. The gut flora has also been shown to synthesize vitamin K, riboflavin, biotin, nicotinic acid, pantothenic acid, pyridoxine, and thiamine. Most of these, in fact, are B vitamins that are water-soluble. Researchers have identified correlations between a disturbance in gut microbiota and autoimmune diseases. While it might be strange at first glance, a more in-depth look will reveal that roughly 70% of our body's immune cells are found in the gut. This means that our immune system development relies largely on establishing a well-balanced and diverse gut microbiota. While we are discussing the effects of gut microbiota on the immune system, it is vital to mention the implications of having a weakened immune system. Firstly, people with a weak immune system are more likely to get infections. Furthermore, a disturbance in these gut microbial communities can easily cause immune dysregulation, leading to autoimmune disorders. In fact, asthma, IBD, colorectal cancer, bacterial vaginosis, type 2 diabetes, obesity, and many other illnesses have been proven to be influenced by a dysregulation in gut flora. A weak immune system may predispose the individual to get frequent infections, and the illnesses might be more severe or harder to treat. These individuals might also have frequently recurring infections such as pneumonia, bronchitis, and skin infections. Moreover, they are more likely to experience inflammation of the internal organs, blood disorders such as anemia, digestive issues, and growth delays in children. The following symptoms could be a sign of an unhealthy gut. Symptoms such as gas, recurring bloating, constipation, frequent diarrhea, and heartburn could be a sign of an unhealthy gut. A healthy gut does not struggle to process food and eliminate waste. The following conditions can be a result of an unhealthy gut. Symptoms such as upset stomach, weight changes, sleep disturbances, skin irritation, sugar cravings, and food intolerances could be signs and symptoms of gut problems. The human gut microbiota consists of trillions of microorganisms as a hidden metabolism organ. Growing evidence indicates that gut microbiota appears critical in maintaining intestinal homeostasis and improving metabolism health. It is well known that intestinal flora dysbiosis is closely related to development of various chronic diseases. These include colorectal cancer, type 2 diabetes, inflammatory bowel disease, and other conditions we've already mentioned. The occurrence of these diseases may be due to the damage of intestinal mucosa and decrease of bacterial abundance. The gut microbiota can maintain the health of the host by regulating development and function of metabolism, epithelial barrier integrity, and immune system. Bifidobacteria, for instance, is one key genus in the gut microbiota of mammals. We shall now discuss some of the effects the gut microflora has on our health. Starting with upset stomach. A healthy gut does not struggle to process food and eliminate waste. The following symptoms, particularly if experienced frequently or long term, may be a sign of gut problems. These include gas, bloating, constipation, diarrhea, and heartburn. Something interesting and recently discovered is the relation between gut microbiota and weight changes. The bacteria in our gut not only plays an important role in digestion, but research indicates that our microbiome could also play a major role in whether or not we become obese. Obesity and obesity-related metabolic disorders are characterized by specific alterations in the composition and function of the human gut microbiome. Mechanistic studies have indicated that the gastrointestinal microbiota can influence both sides of the energy balance equation, namely as a factor influencing energy utilization from the diet and as a factor that influences host genes that regulate energy expenditure and storage. Moreover, its composition is not fixed and can be influenced by several dietary components. The fact raises the attractive possibility that manipulating the gut microbiota could facilitate weight loss or prevent obesity in humans. Emerging as possible strategies for obesity prevention and/or treatment are targeting the microbiota in order to restore or modulate its composition through the consumption of live bacteria such as probiotics, non-digestible or limited digestible food constituents such as oligosaccharides, known as prebiotics, or a combination of both, known as symbiotics. Another effect that has been observed because of gut microbiota is related to sleep or sleep deprivation. Good sleep and mood are important for health and for keeping active. Numerous studies have suggested that the incidence of insomnia and depressive disorder are linked to biological rhythms, immune function, and nutrient metabolism. But the exact mechanism is not yet clear. There is considerable evidence showing that the gut microbiome not only affects the digestive, metabolic, and immune functions of the host, but also regulates host sleep and mental states through the microbiome gut-brain axis. Preliminary evidence indicates that microorganisms and circadian genes can interact with each other. The characteristics of the gastrointestinal microbiome and metabolism are related to the host sleep and circadian rhythm. Moreover, emotion and physiological stress can also affect the composition of the gut microorganisms. The gut microbiome and inflammation may be linked to sleep loss, circadian misalignment, affective disorders, and metabolic disease. Skin irritation. The importance of microbiome diversity has recently been highlighted in research examining the association between skin and gut microbiota and dermatological conditions such as atopic dermatitis, acne, and psoriasis. Although it is apparent that there is a link between the gut microbiota and dermatological disease, the exact mechanism is poorly understood. Current evidence suggests that it is likely due to a combination of both neurologic and immunological responses to environment shifts, resulting in chronic systematic inflammation that can ultimately affect the skin. Though atopic dermatitis is considered a skin disorder, the gut microbiome is also thought to play a role in disease pathogenesis. Several prospective studies show that the colonic microbiomes of infants who develop atopic dermatitis later in life have lower levels of microbial diversity. These prospective studies highlight that irregularities in gut microbiota precede manifestations of atopic dermatitis. In a Dutch cohort, colonization with Clostridium difficile in the first month of life was associated with atopic dermatitis up to age 7, and colonization with Escherichia coli was associated with a higher risk of atopic dermatitis at age 2. In addition, studies of both adult and infant populations have observed greater colonization with Enterobacteriaceae in atopic dermatitis. Alterations in the gut microbiome have also been implicated in Rosacea pathogenesis. A small cross-sectional study comparing the gut microbiota of those with and without Rosacea found several differences between groups, with certain bacteria being more abundant in Rosacea patients and other bacteria populations being less abundant. In contrast with atopic dermatitis, metagenomics showed no difference in the microbiotic diversity of subject groups. Sher et al., for instance, found a decrease in bacterial diversity in the gut of patients with psoriatic arthritis and skin-limited psoriasis. Interesting to note is the circumstantial evidence for a connection between cravings and the composition of gut microbiota. Individuals who are chocolate desiring have different microbial metabolites in their urine than chocolate in different individuals, despite eating identical diets. There is also evidence for effects of microbes on mood. A double-blind randomized placebo-controlled trial found that mood was significantly improved by drinking probiotics such as Lactobacillus casei. Microbes produce a variety of neurochemicals that are exact analogues of mammalian hormones involved in mood and behavior. More than 50% of the dopamine and the vast majority of the body's serotonin have an intestinal source. Food intolerances. Genetic and epidemiological studies showed an association between viral and bacterial infections and the onset of celiac disease and food allergies, suggesting that repeated microbial infections earlier in life trigger food sensitivities, particularly in individuals with more moderate genetic predisposition. In addition to the support provided by clinical and epidemiological studies for an association between intestinal, bacterial, and viral infections and food sensitivities, the role of a dysbiotic gut microbiota has also been evoked. Indeed, several groups have reported intestinal dysbiosis in celiac disease and food allergy. For instance, it has been shown that changes in key bacterial groups in infancy were associated with the development of food allergy later in life. The intestinal microbiota is considered a metabolic organ that vastly complements the host's metabolic activities. One mechanism through which bacteria could affect immune responses to dietary components is through bacterial metabolism of antigens. Depletion of protective bacterial strains from the gut microbiota with beneficial metabolic function, or the presence of viral infections or bacterial opportunistic pathogens could affect the risk of developing food sensitivities through a variety of mechanisms. Genetic predisposition will probably influence the manner in which the host responds to the environment pressures. The best understood mechanisms involved in direct effects by bacterial metabolites and modification of antigenicity of dietary substrates, and direct host effects that impair T-cell responses or imprint a pro-inflammatory program in the host. Gut microorganisms can degrade or modify immunogenic food antigens or allergens, increasing or reducing their immunogenicity. Dietary food components that are insufficiently digested by host enzymes become bacterial substrates, leading to the production of metabolites such as short-chain fatty acids, which are involved in gut homeostasis. One key factor in the development of food sensitivities is intestinal barrier dysfunction, which can be influenced by gut microorganisms and pathogens through different pathways. Autoimmune conditions. The gut microbiota maintains the homeostasis of our immune system. Innate and adaptive immunity plays an important role in the containment and clearance of microbial pathogens. Consequently, subsets of innate and adaptive lymphocytes are considered to subsequently shape the gut microbiota in distinct pathways. Specifically, the gut microbiota can influence intestinal functional integrity, barrier strength, and permeability regulation, thereby influencing the immune response, which has been linked to the development of inflammatory disease. Abundant evidence suggests that the gut microbiota may be involved in the initiation and amplification of disease progression in patients with autoimmune diseases. The possible mechanisms include molecular, mimicry impacts on intestinal mucosa permeability, the host immune response caused by the microbiota, and antigenic mimicry. Alterations in gastrointestinal microbial communities have been linked to autoimmune diseases. The gut microbiota can influence or interfere with immune sensing in discriminating between self and non-self, which may contribute to autoimmune disease. Patients with autoimmune diseases commonly display signs of impaired gut barriers, which may result to immune exposure to commensal gut bacteria. In addition, a breakdown in mucosal immune tolerance leads to aberrant and pathological immune responses toward the gut microbiota, which contributes to disease severity. Okay, so at this point, it is only natural to ask, is it possible to improve gut health, given that is so crucial for health and well-being? Can we improve gut health? Well, the good news is that yes, we can improve gut health. But the obvious next question, I would imagine, would come up as, how can we improve gut health? What can we do to improve our gut health? Looking after the health of the gut and maintaining the right balance of these microorganisms is vital for physical and mental health, immunity, and much more. Diet and gut health are very closely linked, but there are other lifestyle changes that can help improve gut health. It is said that all disease starts in your gut, and now we can better understand why. So we are now going through some of the lifestyle changes that we can do to promote gut health. Starting off by reducing the amount of processed high sugar and high fat foods that you can eat that can contribute to better gut health. Eating plenty of plant-based foods and lean protein can positively impact gut health. A diet high in fiber has been shown to contribute tremendously to a healthy gut microbiome. There are also a number of lifestyle modifications that can actively promote the growth of beneficial bacteria, contributing to overall health, and together we are going to take a look at these lifestyle changes one by one. So these lifestyle changes include managing stress levels, getting enough sleep, staying hydrated, investigate food intolerances or allergies, consuming probiotics and fiber supplements, avoiding tobacco, and getting regular screening. Getting enough sleep. Although we can get away with the occasional 4 to 5 hours of sleep, lack of sleep can quickly catch up on us. In general, adults need 7 to 9 hours of sleep. Not getting enough or sufficient quality of sleep can have serious impacts on your gut health, which can in turn contribute to more sleep issues. Try to prioritize getting at least 7 to 8 hours of uninterrupted sleep per night. An unhealthy gut may contribute to sleep or to further sleep disturbances, such as insomnia or poor sleep, and therefore lead to chronic fatigue. The majority of the body's serotonin, the hormone that affects mood and sleep, is produced in the gut. So make it a priority to sleep 7 to 9 hours. If you have difficulty sleeping, there are several things that you can do. This is known as practicing good sleep hygiene. Paying attention to sleep hygiene is one of the most straightforward ways that can set yourself up to better sleep. Strong sleep hygiene means having both a bedroom environment and daily routines that promote consistent, uninterrupted sleep. Keeping a stable sleep schedule, making your bedroom comfortable and free of disruptions, following a relaxing pre-bed routine, and building healthy habits during the day can all contribute to ideal sleep hygiene. Manage stress levels. Stress is an autonomic physical response to anything perceived to be a threat, either physical or psychological. It could be a physical threat of attack or imminent danger, or it could be a psychological threat to your self-esteem or self-confidence. Chronic stress changes gut microbiota composition, as well as inducing behavioral and physiological deficits. The microbial metabolites, short-chain fatty acids, have been implicated in gastrointestinal function, neuroimmune regulation, and host metabolism. Chronic high levels of stress are hard on your whole body, including your gut. There are many ways how you can control and lower your stress levels. Some of the examples may include walking, meditation, getting a massage or using diffusing essential oils, spending time with family or friends, practicing yoga, and even owning a pet might help in reducing stress levels. Stress levels and the proper diet are closely related. When we're overwhelmed, we often forget to eat well and resort to using sugary, fatty snack foods as a pick-me-up. Try to avoid sugary snacks and plan ahead. Fruit and vegetables are always good, and fish with high levels of omega-3 fatty acids have been shown to reduce the symptoms of stress. Something else which is very important for gut health is staying hydrated. Drinking plenty of water has been shown to have beneficial effect on the mucosal lining of the intestines, as well as on the balance of good bacteria in the gut. Staying hydrated is a simple way to promote a healthy gut. Aim at drinking at least 2 liters per day, and try to drink water as opposed to any sugary drinks. Investigate intolerances and get regular screening. If you have symptoms such as cramping, bloating, abdominal pain, diarrhea, rashes, nausea, fatigue, and acid reflux, you may be suffering from a food intolerance. You can try eliminating common trigger foods to see if your symptoms improve. If you are able to identify a food or foods that are contributing to your symptoms, you may see a positive change in your digestive health by changing your eating habits. Reducing processed foods. Reducing the amount of processed high sugar and high fat foods that you eat can contribute to better gut health. Additionally, eating plenty of plant-based foods and lean protein can positively impact gut health. A diet high in fiber has been shown to contribute tremendously to a healthy gut microbiome. Consume probiotics. Fermented foods are rich in probiotic bacteria, so by consuming fermented foods, you are adding beneficial bacteria and enzymes to your overall intestinal flora, increasing the health of your gut microbiome and digestive system and enhancing the immune system. A typical example of fermented foods which provide probiotics include yogurts. Greek yogurt, for example, is an excellent source of both probiotics and is also rich in protein. To reduce levels of inflammation, aim for an overall healthy diet. Recent evidence demonstrates that an anti-inflammatory diet can help gut health. If you're looking for an eating plan that closely follows the tenets of anti-inflammatory eating, consider the Mediterranean diet, which is high in fruits, vegetables, nuts, whole grains, fish, and healthy oils. In addition to lowering inflammation, a more natural, less processed diet can have noticeable effects on your physical and emotional health. Increase your fruit and vegetables intake. A study by Climeco et al. In 2018 demonstrated that a diet rich in fruits and vegetables and other high-fiber plant-based foods improves gut bacteria diversity within just 2 weeks. Researchers assessed gut bacteria composition in 248 participants over a 2-week dietary intervention that increased fiber intake. Those who consumed more fruits and vegetables and grains improved gut bacterial diversity when compared to participants who did not change their diet. Beans and legumes. Data demonstrates that both beans and legumes supplementation primes the colonic microenvironment, influencing both the microbiota and host tissues to improve overall gut health and barrier integrity. Beans and legumes are some of the most underrated foods. They are excellent sources of dietary fiber, protein, B vitamins, and many other important vitamins and minerals. There is good evidence that they can help reduce blood sugar, improve cholesterol levels, and help maintain a healthy gut. So including beans and legumes such as lentils and other pulses is a good way of promoting gut health. Eating whole grains can also promote gut health. Whole grain means that all 3 elements of the grain are present. It is not stripped of things like the fiber-rich outer layer, the inner part and the starchy part. Refined grains like white bread don't contain all of these 3 parts. Why are whole grains so good for us? Because whole grains can contain up to 75% more nutrients than refined cereals. They contain fiber and B vitamins as well as other nutrients. They can reduce our risk of some forms of cancer such as bowel cancer and keep our digestive system healthy. Consuming olive oil as opposed to other fats. Olive oil is rich in monounsaturated oleic acid. This fatty acid is believed to have many beneficial effects and is a healthy choice. About 14% of the oil is saturated fat, whereas 11% of polyunsaturated, such as omega-6 and omega-3 fatty acids. But the predominant fatty acid in olive oil is a monounsaturated fat called oleic acid. Apart from its beneficial fatty acids, olive oil contains modest amounts of vitamin E and vitamin K. Furthermore, olive oil was found to help in inflammation. Olive oil seems particularly beneficial when combined with fish oil. another source of anti-inflammatory omega-3 fatty acids. Combined together, these lifestyle changes promote good gut health. A healthy diet is beneficial not only for reducing the risk of chronic disease, but also for improving mood and overall quality of life. While I sincerely hope that you enjoyed this presentation, I thank you very much for your attention.
Our next speaker is Miss Mariella Porter. She is a nutritionist registered both in Malta and in the UK. She has obtained her master's degree in human nutrition from a UK university, where she studied within the clinical sciences department. Her research work involved the forefront study of food hypersensitivity amongst Maltese pediatrics population. Ms. Porter is the author of the document entitled Safety Recommendations on Food Hypersensitivity in Maltese Schools. And she is very active in promoting the safety of children with food allergies and intolerance. She is also currently furthering her research work at doctorate level, where her areas of specialization are food hypersensitivity and disordered eating. Ms. Porter is also a warranted educator and a lecturer in nutrition and health. We are very pleased to have Ms. Porter as one of our speakers. As I said already, she is very specialized in this area. Her presentation will discuss food allergies and intolerances and the FODMAP diet.
I welcome you for this presentation titled Food Hypersensitivity, Allergies and Intolerance. I start by introducing myself. I am Mariella Porter, a registered nutritionist, and my area of research and specialization is food hypersensitivity. Some ask me, why is this an area of interest? And in fact, it has always fascinated me how one man's food is another man's poison. One person can consume a certain food ad libitum in big quantities and nothing happens to that person, while another person would consume small amounts of food or chemicals, or there would be cross-contamination and the person would react to the food. So what will we cover today during this presentation? So the learning outcomes for today are food hypersensitivity classification. We will see how this reaction to food is classified. We will see which foods can cause food hypersensitivity. We will see the differences between allergies and intolerance. What causes reaction to food? Sensitivity to wheat and gluten. It is something that we hear a lot about, but we're going to see, is it an allergy, is it intolerance, or is it celiac disease? We're going to also cover the low FODMAP diet, and we're also going to tackle what food aversion is. So without further ado, let's give a start to this presentation by seeing the classification of food hypersensitivity. According to the European Academy of Allergy and Clinical Immunology Task Force, food hypersensitivity is the general term used to refer to any adverse reaction to food. Unfortunately, the terms allergy and intolerance tend to be misused at times, unfortunately even by healthcare professionals. So today we are going to see which terms should be used in the right setting. So food hypersensitivity is then divided into two sections. We have allergic hypersensitivity. That's when the immunity is involved. That's what usually is referred to as an allergic reaction. So what happens when the immunity is involved in such reactions to food? At times there are antibodies called IgE, and this is what we call an IgE-mediated allergic reaction. This is what people might refer to as the typical type of reaction, and which is usually immediate, which happens within 2 hours of consuming that food. Then there is the non-IgE mediated allergic hypersensitivity. Here the immune system is still involved, but the antibodies IgE are not released in the body. Other antibodies or cells are released when there is this allergic type of reaction. Just to make the topic a little bit more complex, there is also the mixed type of allergic reaction. So we have IgE, when this antibody is released, and also non-IgE mediated when other antibodies or cells are released. So all this is referring to an allergy, an allergic reaction where the immunity is involved. On the other hand, then we have the non-allergic type of hypersensitivity, so the immune system is not involved, and this is what most people would refer to as an intolerance. So which food causes hypersensitivity? Really and truly, unfortunately, it's any food, whether it's natural or any added chemicals to food. And when it comes to the main causes of an IgE-mediated food allergy, so it's an allergic reaction and the IgE antibody is released, there are particular main groups which are usually mentioned, and these are milk and obviously its products, eggs, we've got fish, crustaceans, so we have prawns, crabs, lobster, this is the shellfish family, we have the tree nuts and the peanuts, and a little remark here, peanuts are not in the same group of tree nuts, they are actually legumes, there's soya and there's wheat. But really and truly the list is extended, and these are other food groups to which people can react. And it ranges from meat, seeds, celery, mustard, food preservatives, and the list actually goes on. So if we had to give a look at the spectrum of IgE-mediated food allergy, we're going to start by specifying on this group of allergic reactions. We're going to see the reactions and that one would see in such situations. And they can range from respiratory, ocular, all the way up to cutaneous, and there can be more than one symptom, so we have a generalized effect. So some of the symptoms, for example, respiratory, we can have asthma, so the person can experience things like coughing, shortness of breath, there could be decreased exercise tolerance, and also wheezing. Other things like rhinitis, so the person would experience sneezing, a runny nose, nasal obstruction or itchy nose, cough, or voice changes. Things could be ocular, so here we have changes in the eyes, we could have redness or itchiness, there could be lacrimation. There could also be throat discomfort in oral or pharyngeal or gastrointestinal changes in the body, or mouth and tongue itchiness or burning sensation. The reaction could also be cardiovascular. So here, the person could experience hypotension, so there is a lowering in the blood pressure. There could also be vascular collapse, so besides low pressure in general, there could also be low pressure and collapsed arteries and veins. When it comes to skin reactions, there could be things like reactions like urticaria and angioedema. And at times, the reaction is generalized, so you could have anaphylaxis, which could be food dependent. So it's just a reaction as soon as the person consumes the food, or it could also be exercise-induced anaphylaxis. That's when the person is allergic to a certain food, but if the person exercises after consuming this food, there would be anaphylaxis. And in anaphylaxis, there could be a range of symptoms starting with rash, puking, vomiting. There could be the person is out of breath. There could be a lowering in the blood pressure. Other reactions, when the reaction is IgE mediated, when it comes to respiratory, that could be rhinoconjunctivitis. So we have a combination of symptoms starting from nasal congestion, runny nose, postnasal drip, itchiness in the nose and the eyes. So this also verges with ocular. When it comes to specific ocular reaction, there could be conjunctivitis. So here we have an inflammation or swelling of the tissues, the tissue lining around the eyes. There could also be periorbital edema, so here we have swelling around the eyes. More reactions when it comes to oral, pharyngeal, or gastrointestinal. There could be gastrointestinal anaphylaxis, and this is when the person experiences nausea, vomiting, abdominal cramps, or diarrhea. Or there could also be oral allergy syndrome. It's also referred to as pollen food hypersensitivity syndrome. This is when the person is not specifically allergic to the food protein, but the person is allergic to the pollen on the food. And this is when sometimes the reaction to the food is seasonal. So when there tends to be more pollen in the air and on the food itself, the person can have a greater allergic reaction. Other cardiovascular reactions in IgE-mediated allergies, there could be arrhythmia, so the person experiences irregular heartbeat, more skin reactions like morbilliform rashes or red flushes. So as one can see, the range can be very vast. So really and truly, what causes these types of allergic reactions? Unfortunately, like so many other conditions, it all starts with the genes. In fact, we also realize that these allergic reactions tend to run in families, so there's in most cases a family history of food allergy. Yet, there is always a famous gene-environment interaction. So there are certain factors which tend to trigger these genes to cause these allergic reactions. And we're going to see some of these environmental factors, starting with the type of birth delivery. When a child is born through a C-section, through a cesarean section, the child is being born through a sterile environment. So there isn't the encounter with the germs which can build up the child's immunity. So a sterile environment tends to reduce the child's immunity and increase possibly the food allergies or reactions to food, especially if there is always already a genetic predisposition. Even breastfeeding and its duration tends to have an impact. Studies have found that the longer breastfeeding is continued, and if it is provided for the child, the risk of an allergic reaction to food is diminished. As you can realize, I am not saying that there is definitely no risk. There were cases where all these environmental factors were absent, so you could have a child who has natural birth, a child who has been breastfed for a long time, other factors were not present, and still the genetic predisposition was strong enough for the allergic reaction to happen. Yet, if these environmental factors are taken care of, even the intensity of the food allergy could also differ. Also, modification in infant feeding practices could have an impact on an increased risk of food allergy. With time, natural food has been replaced with food in jars and processed food. This might have a different amount of nutrients in it, different amount of good natural bacteria in them, which could increase the gut flora. It could have more salt and more sugar, and this could have an impact on the microbiota, on the gut flora, which could increase possibly also the risk of a food allergy. As I also already mentioned, there's an increase in the processing of food, especially even from a young age, and there is a decrease in gut microbiota, which could also be due to an increase in antibiotic usage. When antibiotics are used, these antibiotics don't know which specific bacteria they need to kill or not, and sometimes they end up killing the wrong bacteria. They end up destroying the good gut bacteria which help us with fermenting and breaking down of food, and this could increase the risk of food allergy. So that's the use of antibiotics, and also a lower level of vitamin D has been found to increase the risk of food allergy. And we might think we live in sunny Malta, so we don't have this risk, yet unfortunately a high percentage of Maltese people have been found to have a low vitamin D level. So even if we are aware that vitamin D should increase when we are exposed to sunlight, how much are really enjoying the lovely outdoors, and we are increasing our vitamin D level. So one should be aware that this vitamin D is also important to prevent food allergies. Also, the timing of allergen introduction. Quite a number of years ago, there was this notion that certain food groups which tend to cause allergy, just to give an example, for example, peanuts and nuts, should not be introduced early on in life, because there was this idea that if they are introduced, the risk of allergies would increase. To the point that certain food groups, including, as I already mentioned, peanuts and nuts, were also recommended to be left out during pregnancy. Today, we know otherwise. All research or updated research is showing that the earlier food groups are introduced, the lesser the risk of an allergic reaction. What about the spectrum of non-IgE mediated food allergy? So now we are still focusing on allergies, but we are specifically going to refer to those reactions where the antibody IgE is not released, but other antibodies or cells are released during the allergic reaction. And here we still have a range starting from respiratory, like Heiner's syndrome. This is quite rare, but it can still happen in infants. It's food-induced pulmonary hemosiderosis, which is caused by cow's milk. There's cutaneous, skin-related, so things like contact dermatitis or dermatitis herpetiformis, or oral pharyngeal or gastrointestinal, like food protein-induced proctocolitis or proctitis, and here there is inflammation of the rectum or the anus, so the person might experience pain or itchiness in these areas. There could be food protein-induced enterocolitis or enteropathy, okay, or esophagitis or gastroenteritis. So all these could be a result not of IgE, of the typical type of allergic reaction that perhaps most people are aware of, but it's still a type of allergic reaction. As I said earlier, sometimes there are mixed IgE and non-IgE mediated food allergies. And here the range is still from respiratory to cutaneous to oropharyngeal or gastroenteritis, starting from oropharyngeal or gastrointestinal. Here we have a range which also is similar to what I mentioned before, where there is the non-IgE mediated food allergy. If we go to respiratory, we have things like asthma, and here it can be a little bit tricky to pinpoint that it's being caused by food, because asthma is also the result of aeroallergens, but one would start excluding asthma as a result of particles in the air, and if the asthma still persists, one might question if this could be caused by food. And as we'll mention even in the workshop, there are specific tests which would be carried out to find if the asthma, for example, in this case, is food related. If it's skin related, things like atopic eczema and atopic dermatitis. So, what causes these non-IgE mediated and mixed IgE and non-IgE mediated food allergy? So when we spoke about the IgE mediated, we said that mainly is genetics, and then there are environmental triggers. Unfortunately, to date, the underlying cause or causes of most of these types of allergy are not clearly understood in all cases, but what we really know about is mainly celiac disease. And some might be surprised that I am mentioning celiac disease here in the section with allergies, because we don't tend, at least the majority of people don't tend to relate celiac disease with allergy. In fact, celiac disease is not the typical IgE mediated food allergy, but it is a non-IgE mediated type of food allergy that's according also to the definition which is given by food hypersensitivity. It is an autoimmune disorder. Cells are released whenever the body is fed, whenever the intestines receive gluten. So here we have a reaction. It's an autoimmune reaction. It is an allergic type of reaction whenever gluten is ingested in the body. What happens during these non-IgE food allergic reactions? So other antibodies, as I mentioned earlier, besides IgE could be involved. Cells are found to be mainly involved, and here we have cells like T cells and eosinophils. And now this also, we can also move on to the food intolerance. So we've tackled the allergic type of food hypersensitivity. That's when the immunity is involved, whether it's by IgE antibodies, other antibodies, or by other cells. Now we're going to tackle specifically what is called as non-allergic food hypersensitivity, or as most people know it, it's food intolerance. Over here, the body's immune system is not involved, and it's the result of reactions. They could be reactions to natural substances in food or to artificial chemicals due to enzyme deficiency. So this could also be a cause, or due to an imbalance in the gut flora, the microbiota, these small organisms which are found in our gut. The interaction between genetics and environmental factors is only understood in a small fractions of these food intolerances. In fact, just to give an example, one which is really known where it's coming from, it's lactose intolerance. Okay, we tend to realize that certain people can keep breaking down lactose in the diet, enjoying their milk, enjoying their yogurts and cheese, whilst others, either at a young age or at an older or later stage in their life, they cannot consume it anymore. So what is happening here? Most mammals, all mammals actually, have the enzyme lactase, which helps them to break down the sugar lactose in milk. Yet, in mammals, as the child starts growing, as the little one starts growing, they are weaned off from their mother's milk and they stop consuming milk. So really and truly, they don't need this enzyme lactase anymore to break down lactose. Now, the same should have happened in us as humans, because biologically we are not prone to keep consuming milk because we are weaned off from the maternal milk. This enzyme lactase should not be produced any further. So really and truly, what is happening in those people without this enzyme and those who cannot break down lactose, it's actually what should be happening, like what's happening in all the mammals. Yet a percentage of humans evolved to keep producing this enzyme lactase because humans have loved milk, they wanted to keep introducing it in their diet, so the body has adapted. And there was this evolutionary change towards breaking down lactose further from infancy. So, reaction to natural substances and food additives. What is happening here when there is a reaction and what are these substances? So here we're going to see a range, and this is only some of the chemicals that the body can react to. And I'll start off with carbohydrates. So here we have things like fructose, sucrose, glucose, lactose. Some of these things are also natural things. And there could also be artificial sweeteners, like for example those which end with the letters OL, like sorbitol. Now, the symptoms usually are meteorism or flatulence. There could be nausea and also diarrhea. Benzoate, so here we have chemical preservatives in food. Usually the symptoms are chronic urticaria, asthma, atopic dermatitis, rhinitis, at times anaphylaxis, that's quite rare, and flare around the mouth. Biogenic amines, so these are low molecular weight, they are organic compounds, and they are found naturally in food, especially in the fermented ones, and they are also formed by microbial breakdown of amino acids. And in fact, they are found in meat and fish when especially this is poorly stored. So the symptoms are increased gastric acid, increased heart rate, headache, urticaria, pruritus, tachycardia. So the symptoms can also range, and at times it is also difficult to pinpoint if it is an intolerance or allergic reaction simply from the symptoms, because as you can see, there can also be an overlap. Salicylatates, these are chemicals found naturally in plants, so in fruits and vegetables. They are also found in aspirin and in other pain relief medications. The symptoms can range from rhinitis, asthma, inflammation, and at times they tend to be blamed for also hyperactivity in children, especially if consumed in large quantities. Other substances, things like caffeine, natural substance, we know where it's found, like in tea, coffee beans, etc. You'll find people can have 4, 5 or more coffees a day and they're fine. You'll find others who will take one coffee in the morning and they complain that they find it very hard to sleep at night. So that could be a sign of an intolerance to it. Other things like arrhythmia, gastrointestinal disturbances, restlessness, headaches. Another substance is monosodium glutamate, is also known in short as MSG. It's found in tomatoes, grapes, cheese, mushrooms. It's also used as a flavor enhancer. If consumed in large amounts, it can cause things like asthma, headache, urticaria, other reactions, including blamed for hyperactivity in children. Sometimes it's called the Chinese restaurant syndrome because it's used quite often in Chinese cuisine. Artificial colors and preservatives, in some people, they can cause meteorism, flatulence, nausea, and diarrhea. I repeat, we are not saying here that every time that a person consumes this food, the person is going to get these symptoms. There are people who can consume these foods ad libitum with no reaction, while others would take small amounts and the reaction would happen. Things like sulfites found usually in canned and frozen things. Again, this could range from urticaria up to anaphylaxis or rhinitis. Then we can have proteins like gluten, and gluten is a group actually of proteins which are found not only in wheat but in other grains like spelt, rye, and barley. And another protein is found in oats is avenin. So some people are intolerant to these, and the symptoms that they experience are things like bloating, meteorism, flatulence, constipation, or diarrhea. At times, as I mentioned earlier, the intolerance could be a result of enzyme deficiency. So if a person doesn't have the enzyme lactase, they cannot break down lactose in milk and dairy. So there could be meteorism, flatulence, nausea, or diarrhea. If they are missing, decreased, or absent pancreatic enzymes like amylase, which breaks down starch, lipase, which breaks down lipids, and proteases, which break down proteins, the person would experience diarrhea, meteorism, and all the other symptoms simply because these chemicals in food cannot be broken down. If glucose 6-phosphate dehydrogenase, in short called G6PD, is absent, we say that the person has G6PD deficiency, and here the person could have hemolysis and anemia when consuming mainly fava beans, broad beans. Yet the person should also be quite careful with other beans or other food like berries, dyes, and added chemicals. There's also at times the deficiency of phenylalanine hydroxylase. When this is absent, we say that the person has PKU, phenylketonuria, and the person needs to avoid high protein food and also aspartame. So it's quite a restricted diet, which should start from the early months for the person to survive actually. We hear a lot about wheat and gluten. Yet, unfortunately, there's a lot of mix-up of whether it's an allergy, celiac disease, or intolerance. So usually, if the reactions include rashes, there's puking, vomiting, especially if the reaction happens very close to consumption of the food, highly likely there is a wheat allergy. This is just an assumption. The right tests need to be carried out. If the allergy tests and the right allergy tests show that the person is not allergic to wheat, then the question is the person celiac or is the person intolerant to gluten? Sometimes allergy tests are not actually needed from the symptoms because, for example, the person doesn't get immediate reaction. Could be there's a delayed reaction. So the symptoms are hinting more celiac disease or gluten intolerance. The worst thing that a person could do is stopping gluten immediately on their own. We always recommend that first the celiac disease test, the celiac screening test is carried out. And here I emphasize that for this to give us the right test, the person needs to be actually consuming gluten. Okay, so the person should not stop the gluten because otherwise, if we need to do the celiac disease, the person needs to reintroduce the gluten in their diet. If the celiac disease is positive, then we know that the person is celiac. If we get a negative celiac disease result, it's not in the person's head, The person, yes, is still reacting to gluten, but in that case, highly likely the person is gluten intolerant. It's what we tend to find even in scientific studies referred to as non-celiac food hypersensitivity. Recently, we've started hearing about the low FODMAP diet, but what are FODMAPs in reality? So here we are referring to fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these are chemicals which are found naturally in food, mainly in plant food, that is mainly in fruit and vegetables. Yet some people started showing symptoms of reaction to these food groups, even if they are natural food, and even if they have the notion of being considered as healthy. So there was the creation of the slow FODMAP diet. So meat, fish, and eggs, they are fine in this diet in their natural form because they are not products of plants. The original low FODMAP diet was rather restrictive and excluded certain food groups from one's diet. Yet nowadays we have a more updated version, and this is what I'll explain. And basically the person needs to be careful with certain fruit and vegetable products, and the person needs to be careful with high sugary food. And like this, the person would not have symptoms of indigestion where the person cannot break down the food. There could be bloating, there could be diarrhea, there could be an upset stomach. So when it comes to fruit, example, if someone consumes one small medium unripe apple, the person might be fine. But if the person consumes the apple plus another fruit or two, there could be symptoms. So the diet really focuses on controlled portions of food. When it comes to vegetables, for example, if someone takes 2 thin slices of beetroot, the person is going to be fine, but if they start adding more and more vegetables in the same plate, they are going to react. When it comes to cereals and grains, this type of diet tends to recommend consuming gluten-free version. Rice and oats tend to be tolerated by most people because then there are also individual variances, and half a cup of uncooked form tends to be accepted. Even cornflakes, if it's pure cornflakes, not which does not contain gluten, half a cup is usually tolerated. When it comes to dairy, hard cheeses tend to be fine because the protein is changed and the lactose is very minimal or absent. Soft cheeses need to be avoided, and the persons, those following the low FODMAP diet, tend to go for the lactose-free version or the non-dairy alternatives. When it comes to nuts, a closed fist, that's a portion which tends to be tolerated, and seeds like around 1 tablespoon. Beans and legumes, not more than 1/4 to half a cup. Sweets, if consumed, they have to be as low in sugar as possible. So, for example, if it's chocolate, definitely higher than 85% cocoa, so there would be a reduction in the sugar content. And if any biscuits, for example, are consumed, 2 plain ones can be accepted. Herbs and spices, they are all fine in this diet. They don't give a reaction as long as there aren't onion and garlic involved, because these two tend to give some trouble. When it comes to alcoholic drinks, one also needs to moderate. So like 1 beer would be fine. Half a cup of diluted juice is also fine, or 1 glass of wine. Once the person starts to increase the amount, they can have trouble with digestion. So here it's more a matter of the person is intolerant, the person is not breaking down this food well. But once the food groups are controlled and there is the right food combination, the person can also enjoy his meal without any discomfort. We've mentioned mainly allergies and intolerance, but I would also like to say something short about food aversion. So this picture explains it all. We have this boy who is put off broccoli, like probably most children and sometimes even adults. But it's not just being put off. At times when children and even adults consume certain food, they tend to have reactions usually related to the digestive system, like nausea or puking. But if allergy tests are carried out, for example, they would be negative. So what is happening here? Here we have a strong feeling of dislike or fear to consume some food, yet there is no underlying hypersensitivity. So why is there a reaction? Let's just take this example, which probably we've all experienced at a young age. Let's take a child who was unwell with fever and consumed an orange or orange juice when the child was in the state, and the child threw up. The brain will register that throwing up, it links it with the orange, so as defense mechanism, the child will be put off the orange because the brain is registering that the orange makes me puke. And every time the child or eventually the adult takes the orange, there might be these symptoms like nausea and or puking. Now, the only way out to find if there is really an allergic reaction or is just food aversion, sometimes this same food is introduced, there is blinding of the food, it's hidden in other food, the person takes it, there is no reaction, so in that case, it's definitely not food hypersensitivity. So that is all from my end for now. I really thank you for your attention. Later on, during the workshop, we will tackle the topic more from a more practical point of view. So we will tackle how to deal with food allergies and intolerance, even in daily life, and how to test for them.
Good afternoon and welcome to the second presentation I'll be delivering today. This time this workshop is entitled Healthy Lifestyle and Nutrition. Essentially, what is a healthy lifestyle? Most of us would think that we are doing a fair job at maintaining our health with good eating habits and physical activity whenever we manage to fit it in. But is that enough to be considered healthy? According to a recent study, very few adults actually meet the criteria for a healthy lifestyle. The study published in the Archives of Internal Medicine showed that only 3% of Americans, for instance, got a perfect score on what the authors say are the 4 basic criteria for healthy living. So how well do we measure up on the researchers' criteria for healthfulness? According to the study, you need to answer yes to the following 4 questions. Are you able to maintain a healthy weight, a BMI of 18 to 25, or are you successfully losing weight to attain a healthy weight? Do you at least eat 5 servings of fruits and vegetables daily? Do you exercise 30 minutes or more? Do you exercise 5 times a week? And you should answer no to the question, do you smoke? Everyone knows that smoking is bad for your health. Smoking, in fact, is considered one of the major risk factors for certain disease, and is considered an unhealthy habit, of course. Unhealthy habits such as smoking, poor nutrition, excess alcohol consumption, and physical inactivity, collectively known as SNAP, risk factors are among the major causes of morbidity and mortality. These risk factors contribute to the development of chronic disease such as cardiovascular diseases and cancer, which are among the leading causes of death worldwide. Together we shall be looking at the risk factors that predispose us to morbidity and discuss their detrimental effects on health. Then, during the course of this presentation, we shall also discuss behavioral changes to mitigate these risk factors and lead a healthier lifestyle. Lifestyle risk factors such as smoking, overweight, obesity, alcohol use, physical inactivity, and unhealthy diet are associated with chronic disease such as diabetes mellitus, cardiovascular diseases, and several types of cancer. However, these risk factors are not randomly distributed across populations, but often occur in a combination with each other. The clustering of risk factors is associated with a higher risk of disease than can be expected from the individual risk factors alone. Data are emerging that stress is associated with risk of chronic disease. Work-related stress has been associated with risk of metabolic syndrome, coronary heart disease, acute myocardial infarction, and potentially even type 2 diabetes. The World Health Organization recently recommended an approach to prevention of chronic disease, which focuses on tackling multiple modifiable risk factors. Due to time constraints today, of course, we cannot discuss all the risk factors and ways to mitigate each of these stressors. However, we shall be looking and focusing on some of the main ones, which can be modifiable risk factors, and that includes poor diet, physical inactivity, stress. We shall also mention obesity, among other risk factors. Let me start off by discussing stress, because stress is one of the major risk factors when it comes to cardiovascular disease. So what is stress? Stress is an automatic physical response to anything perceived to be a threat, either physical or psychological. It could be a physical threat of attack or imminent danger, or it could be a psychological threat to your self-esteem or self-confidence. Stress is a natural human reaction to a demanding situation. Facing stress is part of our daily lives. We constantly face stress in our daily lives, at work, at home, or even in social settings. By understanding stress, identifying the causes, and having measures to cope with stress, we can better manage our stressors, manage stress. What are stressors? A stressor is anything your mind thinks may harm you and that triggers a response. These also can be referred to as stress buttons or stress triggers. Stressors vary considerably from person to person. Not everyone perceives and reacts to a particular threat in the same way. You might see a change in your driving route as exciting and different, while another driver might feel confused and anxious. Therefore, what you see as routine and enjoyable may seem unbearable and threatening to someone else. Urbanization, increasing mobility, and the globalization of information and business continue to fuel accelerated lifestyles and generate rising levels of stress for many. In particular, work-related stress has become a substantial health challenge in many countries with significant impact on business productivity. Without radical changes to lifestyles, we can expect heightened struggles with stress. Heightened alertness, difficulty focusing, short temper, irritability, and sometimes even breathlessness are all signs of stress. The stress response is an instinctive survival response that prepares you for flight or fight. It prepares you to react mentally and physically in ways that will help you handle a perceived threat. Adrenaline is released to prepare your mind and body for action. Your breathing and heart rate increases, blood sugars are released to give your muscles more power. The brain releases hormones that ease pain and make you more alert. You get a nervous feeling like butterflies in your stomach. In an instant you have extra strength, alertness, energy, and endurance to protect yourself. Any stressor that your brain and nervous system perceive as threatening will put you on the same red alert. Stress is not always unhealthy. It can actually motivate you. Stress can cause positive change and action. The pressure of a project deadline at work, for instance, or filling your taxes on time may motivate you to concentrate a bit harder and manage your time better. Stress can prompt you to create new ways to achieve your goals. However, the stress becomes overwhelming or is chronic if it is ongoing for a long time. The physical changes from the heightened state of alertness can cause physical, mental, as well as emotional problems. Common consequences of overwhelming or chronic stress are many and include anxiety, poor concentration and low presence, decreased personal effectiveness or productivity, health and safety consequences such as accidents. It can also lead to heart disease and asthma, interpersonal problems and depression. So finding alternative lifestyle and stress reduction techniques is extremely important. This workshop, in fact, will take you through and give you some tips on how to manage your stress. So the first tip I would like to share with you is called the sandbag exercise. Use your imagination to relax when you're feeling tense and stressed out. This exercise only takes around 5 to 10 minutes and you can practically do it anywhere, even at the office. So find a quiet space where you can be alone for 5 to 10 minutes. This is a visualization exercise. So sit comfortably upright, close your eyes, breathe normally, and visualize yourself as a burly bag full of sand, full of tension. Your feet are at the bottom corners of the bag. The corners suddenly burst open and the sand begins to run out. Feel the sand run out of your feet and all the tension that you feel run out too. Completely empty the bag of all the sand and all the tension. This is only one of the many things that you can do to manage your stress. Here are some other ways to mitigate stress. One important thing to reduce stress is to plan ahead. Planning, especially during a busy time, helps us to think clearly as we formulate the ideas and rehearse the possible outcomes. List down your tasks, prioritize them, delegate when possible. It's also important to mark them when completed to feel that sense of achievement. Maintain good connections. Connect with friends and family regularly face-to-face or by phone given the current circumstances, or you can use even social media to keep in touch. Have a laugh, share joys and sorrows to take the pleasure of managing this alone. A problem shared is a problem halved. Don't be afraid to ask for help or reach out for some support. A vital, often neglected component of everybody's overall health and well-being is sleep. Sleep is important because it enables the body to repair and be fit and ready for another day. Getting adequate rest and sleep may also help prevent excess weight gain, heart disease, and increased illness duration. Make your bedroom conducive for sleep by controlling light, temperature, and noise levels. Minimize the use of technology 30 minutes before bedtime to relax the mind and unwind. Exercise. We have all heard it many times before, regular exercise is good for you. Exercise is an excellent way of reducing stress, but has other health benefits too, and the good news is that it's never too late to start exercising. You can start slowly and find ways to fit more physical activity into your life. Regular exercise and physical activity provide many health benefits. It helps you control your weight, Along with diet, exercise plays an important role in weight control and preventing obesity. To maintain your weight, the calories you eat and drink must equal the energy you burn. To lose weight, you must use more calories than you eat and drink. So exercise will help you to burn out more energy. Exercise also helps reduce risk of heart disease. Exercise strengthens your heart and improves your circulation. The increased blood flow raises the oxygen levels in your body. This helps lower your risk of heart disease such as high cholesterol, coronary heart disease, and heart attack. Regular exercise can also help lower blood pressure and triglyceride levels. Evidence also suggests that exercise helps the body to manage blood sugar and insulin levels. Exercise can lower your blood sugar level and help your insulin work better. This can cut down your risk for metabolic syndrome and type 2 diabetes. And if you already have one of those diseases, exercise can help you manage it. Exercise also helps to improve mental health and mood. During exercise, your body releases chemicals that can improve your mood and make you feel more relaxed. This can help you deal with stress and reduce your risk of depression. Exercise can also help you in thinking, learning, and judgment skills, and strengthen your bones and muscles. It has also been shown to reduce the risk of some cancers and improve sleep. Exercise can help you to fall asleep faster and stay asleep longer. With so many health benefits, this lifestyle change is definitely worth embarking upon. Make exercise activities more active. Even small changes can help. You can take the stairs instead of the elevator, walk down the hall to a co-worker's office instead of sending an email, wash the car yourself instead of going to the car wash, or park further away from your destination and walk to your destination. There are many ways how to include exercise on a daily basis. You can also be active with your family and friends. Having a workout partner may make you more likely to enjoy exercise, and sometimes the commitment of meeting someone else can even encourage you to push you to do that extra bit and exercise. Keep track of your progress. Keeping a log of your activity or using a fitness tracker may help you set goals and help you to stay motivated. Make exercise more fun. It's very important to have fun during exercise, and there are several ways how you can do that. Try listening to music or watching TV if you're exercising at home, something which we can do at the moment especially. Also mix things up a little bit, like if you stick with just one type of exercise, sometimes it can start getting boring. So try doing a combination of activities. We are experiencing difficult times, but don't forget we are in this together, and we will get through this together. We are going through stressful times constantly. Reading alarming stories in the news or social media, this can even increase the stress and anxiety levels or worry. Be informed, it's okay, read or listen to the news once a day, but plan regular breaks to switch off from the media, especially before bedtime. Set notifications on digital devices to do not disturb at nights and on weekends, so at least you can take a break from the bombardment of negative news. Other lifestyle modifications that we can implement to lead a healthy lifestyle are, of course, avoiding alcohol and cigarettes. I won't be delving deep into these because we all know, the detrimental effects that cigarette smoking has on our health. Drinking water, does more than just quench your taste. It's essential to keeping your body functioning properly and feeling healthy. Nearly all of your body's major systems depend on water to function and survive. You'd be surprised about what staying hydrated can do for your body. Here are just a few important ways water works in your body. It regulates body temperature, moistens tissues in the eyes, nose and mouth, protects body organs and tissues. Every day you lose water through your breath, perspiration, urine and bowel movements, which is why it's so important to continue to take in water throughout the day. For the body to function at its best, you must replenish its water supply with beverages and food that contain water. Water carries nutrients to all cells in our body and oxygen to our brain. Water allows the body to absorb and assimilate minerals, vitamins, amino acids, glucose and other substances. It also flushes out toxins and waste and helps to regulate body temperature. This chart provides information about water requirements. Main factors affecting water requirements include age, physiological conditions such as pregnancy and lactation, physical activity, body temperature and environment, as well as illness and injury. Body water remains relatively constant throughout the day. Over a 24-hour period, intake and losses of water must be equal. As I explained earlier on, there is evidence of a synergistic effect of risk factors where combinations of lifestyle risk behaviors are more detrimental to health than their cumulative individual effects. Poor eating habits, being overweight and obese, are risk factors that combined with other lifestyle risk behaviors put our health at risk, and thus I would like to dedicate the second part of this presentation to nutrition. Eating a healthy diet that includes lots of fruit, vegetables, whole grains and a moderate amount of unsaturated fats, meat and dairy can help you maintain a steady weight. Having a good variety of these foods every day leaves less room for foods that are high in fat and sugar, a leading cause of weight gain. Together with exercise, eating a healthy diet in the right proportions can also help you to lose weight, lower your cholesterol levels and blood pressure, and decrease risk of type 2 diabetes. Healthy eating means taking a proper nutritious diet which has a balance of lean protein, carbohydrates, fats, vitamins and minerals. Healthy eating includes good food which makes the body strong, strengthens the immune system and promotes well-being. Good food like vegetables, fruits, whole grains, cereals, pulses, etc. makes up all the nutrients for a body's requirement. Healthy food also includes some amount of good fats, but then they are low in calories, such as avocado for instance. If you are looking for a healthy diet, then you should definitely avoid fast foods like burgers, fries, and sweetened drinks, as well as sweets, as these are rich in calories and unhealthy fats. The functions of protein in our bodies are quite varied, but as a standard, proteins in the body are constantly being broken down into amino acids and resynthesized to fulfill other purposes, which include acting as enzymes or hormones like glucagon and insulin, as well as antibodies, providing structure to bones, teeth, skin, hair and nails, maintaining fluid balance, transporting nutrients, maintaining acid-base balance that acts as a buffer, and a backup source of energy. Some of the most common sources of protein include poultry, beef as well as fish. Beans are a great replacement for meat as a source of vegetarian protein. Beans and legumes have a number of health benefits, including reducing cholesterol, decreasing blood sugar levels, and increasing healthy gut bacteria. Some of the healthiest beans include chickpeas, amongst others, and are a great source of fiber and protein. Many scientific studies have shown that beans and legumes can help reduce weight, risk factors for heart disease, and potentially even the risk of cancer, especially when they replace red meat in the diet. Adequate calories are always important. If not enough calories are consumed, the body will break down muscle protein for energy. We also require adequate dietary protein for building and maintaining muscle. Evidence suggests aiming for 25 to 30 grams protein at each meal may achieve best muscle synthesis. As we grow older, protein requirements increase. Older people require at least 25% more protein than younger people due to immobility. Also because older people lose protein at a much greater rate when they are immobile. Metabolism of protein. Our ability to process protein and synthesize new muscle becomes less effective as we age. Also due to chronic disease or acute disease, protein requirements increase with acute or chronic disease or wound healing. The protein requirements in younger adults are more or less 0.8 grams per kilogram. For men over 70 years, the requirements increase to 1.07 grams per kilo, and in women 0.94 grams per kilogram. Inactivity, like when patients are bedridden in older adults, results in 3 times more muscle loss when compared with younger adults. When you eat a healthy balanced diet, you replace the high-fat, high-calorie foods with fruits, vegetables, lean protein, and whole grains. The fiber in the whole grains, fruits, and vegetables help you to fill your stomach faster and keep you full for a longer time. This helps you to be satisfied for a long time, thus helping yourself in getting the ideal weight. You can also control your blood sugar. The complex carbohydrates such as whole grain bread, oatmeal, and brown rice helps in lowering the release of sugar into the bloodstream, and thus important for regulating the blood sugar. There are sugary foods such as white bread, fruit juice, or soft drinks and ice cream, which can increase this sugar level, and if this continues over time, your body can become insulin resistant, which can cause 2 different types of diabetes. A diet high in whole foods like fruits, vegetables, whole grains, healthy fats, and lean protein may prevent cancer. Conversely, processed meats, refined carbohydrates, salt, and alcohol may increase your risk. Fruits and vegetables are rich in antioxidants, which seek to neutralize the risk of damaging cells called free radicals. Free radicals have an uneven number of electrons, which makes the cells highly unstable. The body can cope with some free radicals and needs them to function effectively. However, the damage caused by an overload of free radicals over time may become irreversible and lead to certain disease, including heart and liver disease, and some cancers, such as oral, esophageal, stomach, and bowel cancers. Oxidation can be accelerated by stress, cigarette smoking, alcohol, sunlight, pollution, and other factors. Antioxidants are found in certain foods and may prevent some of the damage caused by free radicals by neutralizing them. These include the nutrient antioxidants, vitamin A, C, and D, and the minerals copper, zinc, and selenium. Other dietary food compounds, such as the phytochemicals in plants, are believed to have greater antioxidant effects than vitamins or minerals. These are called the non-nutrient antioxidants and include phytochemicals such as lycopenes in tomatoes and anthocyanins found in cranberries. A wholesome diet is also good for your brain, as it is for your body. If you have unhealthy food, you might get prone to a range of neurological problems. Moreover, deficiency of certain nutrients can increase the risk of depression. Nutrients like potassium helps in the brain cell function. A diverse healthy diet keeps your brain healthy and helps in its proper functioning. Thus, eating a balanced healthy food diet can promote good mental health as well. A healthy diet rich in fruits, vegetables, whole grains, and low-fat dairy can help to reduce your risk of heart disease by maintaining blood pressure and cholesterol levels. High blood pressure and cholesterol can be a symptom of too much salt and saturated fats in your diet. Eating a portion of oily fish, such as salmon and trout, each week can also help to lower your risk of developing heart disease. The high levels of omega-3 fatty acids in oily fish are good for heart health. Omega-3 fatty acids are polyunsaturated fatty acids, a type of fat your body cannot make. The term polyunsaturated refers to their chemical structure, as poly means many of unsaturated, which refers to the double bonds in the structure. Since the human body can't produce omega-3s, these fats are referred to as essential fats, meaning that you have to get them from your diet. Omega-3 fats are a crucial part of human cell membranes and have many important functions, including improving heart health, supporting mental health, reducing weight gain and decreasing liver fat, supporting infant brain development, as well as fighting inflammation. Another tool that can be used as a guide for healthy eating is the glycemic index. The glycemic index can be a useful concept in making good food substitution choices, such as having oats instead of cornflakes, or eating grainy bread instead of white bread. Usually choosing the whole grain or higher fiber option will also mean you are choosing the lower glycemic index option. It's not always possible or necessary to choose all low GI foods. There is room in a healthy diet for a moderate to high GI foods, and many of these foods can provide important sources of nutrients. Remember, by combining a low GI food with a high GI food, you will get an intermediate GI for that meal. The glycemic index ranks carb-containing foods from a scale of 0 to 100. The score indicates the increase in blood glucose from the selected type of food. Foods that are slowly digested and absorbed, for example apples, trickle glucose into the bloodstream and have lower GI scores. Foods that are quickly digested and absorbed, like white bread and cornflakes, have a higher GI score. Some studies show that low GI foods are linked to lower risks of diabetes, obesity, and heart disease. Eating foods from the 5 main groups is a good practice as a general rule to follow for healthy eating. The 5 main groups include fruits and vegetables, potatoes, bread, rice, pasta, and other starchy carbohydrates, The third group is beans, pulses, fish, eggs, meat, and other proteins. This is essentially the protein group. Then there's a group for dietary or dietary alternatives. And the last one is oils and spreads. You should try to choose a variety of foods from each group to help you get the nutrients you need to stay healthy. Health is wealth, but unfortunately, because we are caught up in our busy life, sometimes we tend to forget the importance of looking after our health. With the change in our lifestyle, eating habits have changed drastically. So today, that's why I thought of putting some light on the benefits of a healthy lifestyle. And I sincerely hope that you enjoyed this presentation. Thank you very much.
Now?
Yes, we
Yes,
can.
okay. So basically, we focused mainly on diagnosis first. So we saw how important it is to have the right diagnostic tests. And sometimes it's elimination diet, which is used as just to link it to the first part where everybody was present for the presentation. I did mention that there are different types of hypersensitivity. So if you have a history for an IgE type of allergy, then the right tests have to be carried out for that IgE type of testing. If it is non-IgE kind of allergy, then there could be the other test, which includes endoscopy or sometimes patch testing or elimination diet. By elimination, if it's not allergy, highly likely it would be an intolerance. And we said how all of the intolerance tests out there, unfortunately, they are not scientifically proven, and sometimes they are only measuring how much of the food that we increase, because, for example, they measure the IgG level. So we said that by elimination, we know that the person has intolerance, and we can also have food elimination to see if the person improves. Then there are things like probiotics and enzymes as therapeutics, and this takes us to the point which says how we can treat our intolerances. And when it comes to allergy, we said that thankfully nowadays we also have immunotherapy, which is giving hope to patients. So what before was sort of the enemy of the patient, something that could also kill sometimes the patient. For example, peanuts could give anaphylaxis to a little child. Now, slowly, this is introduced in the person's diet, and it becomes the person's medicine. So basically, we are in this immunotherapy, we are cheating a little bit the immune system and helping it to accept that food in the diet. We also saw how to deal with food hypersensitivity in schools. I mentioned schools specifically because that's where my research was carried out. And we also mentioned how children are susceptible to more spreading. I mean, they hug, kiss each other, share things, and they might not be very knowledgeable, especially at a young age, about allergies or intolerance. So the aim is to always increase awareness in the general population, starting from the young ones. And that's why conferences like these are very important to increase education on food hypersensitivity, whether it is of an allergy or intolerance nature.
Thank you.
Can I ask a question to Mariella?
Yes, you
Hi.
can.
Sure.
Hi. I wanted to ask you, with regards to immunotherapy,
Yes.
where would someone have to go to get access to this type of treatment?
Good question, Mela. Currently, it is being offered even at our main hospital. There is a pediatrician who is specialized in allergy, who is also offering this in the pediatric population. And there is also a consultant specialized in adult allergic reactions who is also offering such immunotherapy. Besides that, it is also offered in certain private clinics, but it is also being offered in our hospital.
Okay, thank you.
Welcome.
As a take-home message for everyone, if you take the gist of what Ms. Shiberas and Ms. Porter are saying, be careful what you eat, be careful what you read, be careful what you choose, which tests you choose. So think before you do something. Take professional advice, read, learn, and choose wisely. Right? Do you agree? So, I don't know whether there is anything else that any one of you wants to say. This was very informative. It was very interesting. I know it was very varied as well. I hope you've enjoyed it. And thank you for joining, for the people who joined, and thank you to the speakers for all your input and all your hard work. I know there was a lot of hard work. People who are not involved in the organization of these events don't even imagine what, all the work that it takes behind the scenes. And running after some people sometimes as well. Well, all right. So I thank you for joining, and I hope you enjoyed it. And I wish you the rest of the day and a nice weekend.